harm reduction, harm reduction, and harm reduction. That's a basic public health principle. And so our aim was to reduce the likelihood
Good morning, ladies and gentlemen. We'll get started with this meeting. I want to thank everyone for attending. We have a good Board of Health agenda today. We have 10 items on the agenda. For those who are in the room with us, the screen at the back of the room in that corner there provides real-time updates concerning where we are in the agenda and what's coming up next. If you're watching online, or on television, you can follow the agenda and debate on your computer, tablet, or smartphone at www.ca/council. But how would you know that if you're not already here? Okay, well, whatever. Okay. So, are there any declarations of interest pursuant to the Municipal Conflict of Interest Act? Seeing none. Confirmation of minutes from the last meeting, June 29th. Moved by Angela. All in favor? Opposed, if any? That's carried. So we'll go through the agenda fairly quickly to see what items will be held either for your comments or additional motions or for deputations or presentations. So the first item is a Public Service Week. We're going to hold that for a second. Second item is Green City, Why Nature Matters to Health. Excuse me, to health. There is a presentation and deputations on that, so we'll hold that. Number 3, the Works 25th Anniversary. There is a presentation on that by the Medical Officer of Health, so we'll hold that. HL 6.4, overdose in Toronto, trends, prevention, and response. We have many deputations, several deputations on that, so we'll hold that. As we do for the next item, fentanyl patch-for-patch policy legislation. I'm considering doing both 6.4 and 6.5 together. They are of one piece. At least for the deputations, and I notice the speakers are common to both. So I'll give you some extra time if you are Susan or Dennis to speak to those issues. Then we have 6.6, which is the interim poverty reduction strategy. We have deputations there, so we'll hold that item. 6.7, amendments to the 2015 audit work plan.
I'd like to hold that.
Okay, Councillor Nunziata will hold that. 6.8, contract with York University for provision of rapid risk factor surveillance system partnership services. We can pass that unless someone wishes to hold that. Okay, moved by Councillor Doucette. Any debate? Any contraries? All in favor? Any contraries? Carried. 6.9 is the operating budget variance for the 6 months ending June 30th, 2015. Any holds? Okay, so we'll move that, maybe by Stacey Berry. Moved 6.9. All in favor? Any contrary? That's carried. 6.10, Toronto Public Health Capital Budget Variance Report for the 6 months ending June 30th, 2015. Any holds? Moved by Elisa. To the staff Suggestion is here to receive. All in favor? Contrary? All carried. Okay, so we've done 8, 9, and 10, so we'll go back to the top of the agenda, which is the Public Service Week, and I'll invite the Medical Officer of Health to introduce this topic.
Thanks very much, Mr. Chair. Toronto Public Service Week, of course, is the one week a year in which we formally recognize the contributions of the civil service for the Government of Toronto. And since under the City of Toronto Act, all employees of Toronto Public Health are city employees, we join with the city in recognizing the tremendous contribution that our staff make to the work of Toronto Public Health. Now, there are a number of activities that are happening both corporately and within Toronto Public Health. Since the board was meeting during this week, we thought it would be a good opportunity for you to hear some staff voices that you don't normally hear from. You're accustomed to hearing from me and the senior management team, but of course there are over 1,800 people working in Toronto Public Health. They're out in the community, most of them every day, doing terrific work. And I think it'd be very helpful for the board to hear a few of those voices directly. So we've asked several of our staff to make brief presentations about their role in the work that they do, so you get a different perspective on the work we do. And I think it's important to recognize that most of the impact that Toronto Public Health has is really happening because of our frontline health professionals out in the community. So I'm just going to introduce the staff who are here joining us today and then invite them to proceed. You're going to hear from Morris Komacach, who's a public health nurse with our Diabetes Prevention Project. You're going to hear from Debbie Hilton and Kathy Conlon, who are public health inspectors, who are lead inspectors for the work that we did for the Pan Am and Para-Pan Am Games this past summer. And there was a tremendous lot of important environmental health work associated with those major events. You're going to hear from Dr. Kainu Zwag, who is a dentist with the Dental and Oral Health Services, a very important program. And finally, from Rebecca Valiani, who's a registered dietitian with our Healthiest Babies Possible program, and she'll tell you what that program is about. So, Morris, I think you're first up.
Good morning. Morris Komacach is my name. I'm a public health nurse with Toronto Public Health in the Department of Chronic Disease and Injury Prevention. Thank you very much. I'm honored today to be here to give you a glimpse into the fulfilling work that I do and many of the frontline nurses like me do in the community. While in the community, I work together with several nurses and public health staff to fulfill the strategic direction of the Toronto Public Health. And while in the community, I am an educator, I'm a facilitator, a community capacity builder, I'm a partner, I'm an enabler, and I am a student, as I learn constantly by listening intently to the members of the community as they articulate and share with me their insights and purview on their realities of everyday life. We build existing communities' capacities, and we leave resources in the community, so the community, in the true sense of health promotion, is able to take charge and control of their health. We identify that the community has strength, and part of the strength in Toronto is the diversity. And we also recognize that many of the Toronto's residents come here with skills that that we help enhance to realign them so they can be able to improve on the ability for uptake of most of the services that we offer them. Part of the services that we work on very intently is the diabetes prevention, which I will speak to passionately. We also acknowledge that health behavior is mediated and moderated through empowering experiences. For example, we allow people to validate their existence and their experiences, and we build on those as a starting point. Personally, as a recent immigrant to Toronto, working with fellow immigrants in most of the communities is an uplifting experience. I stand to represent to them the reality of a dream in a place that offers a lot for many of us if only we embrace and build the capacity to uptake the services that are offered. When I interface with my fellow immigrants, our bond starts with our common experiences as immigrants. And then that stimulates the interest to look at the services that we have and the goodwill on every face that we interact with. Through these conscious indulgences, we engage the communities. We strive for inclusion and excellence to reduce, minimize, and or eliminate health inequities. And yet, we have to remain truly accountable, transparent, ethical, which speaks directly to Toronto Public Health's priority direction. A good example of the work that I have done and I enjoy doing is to promote the prevention, the diabetes type 2 prevention in Toronto through the peer-led initiative program. We go out in the community and we ask the community to step up. We train them with leadership skills and how to work with diversity and how to appreciate. We give them leadership skills. We give them a variety of resources and skills that they need to do the work to engage each other. And in the process, they are able to realize that they have a lot of services that they can benefit from. And through the support of our public health nurses and dietitians, we make very simple and user-friendly resources like this that speaks directly to their everyday experiences. They love our water containers that they carry with them in the city to get hydrated. We speak very passionately about our connection and the value of our older adults in the community and recognize that most times they need our support and we are there when they need us. The peer-led program is part of our diabetes prevention strategy, and Toronto Public Health has been receiving special funding from Ministry of Health and Long-Term Care since 2009 to specifically address diabetes prevention in our day-to-day work. Initially, much of the programming was run by Toronto Public Health staff, but in 2011, our focus broadened to entire city and peer leadership model was incorporated. This allowed us to have a broader impact across the city. To reach some of the communities who are at increased risk of diabetes, but are also harder to reach. The evaluation findings showed that the peer-led leadership initiative component of the program has been very effective in helping us to reach community members at high risk for developing type 2 diabetes. The program activities were also effective in increasing program participants' knowledge of risk factors for type 2 diabetes and promoting positive behavior change to reduce the risk of developing the disease. But the benefits of the program go way beyond increasing people's knowledge and shaping health behaviors at the individual level. For example, we spend time building individual and community capacity to lead and seek for health services. We enhance social inclusion through this programming. We set pathways for gainful employment. We increase our awareness about chronic illnesses, screening services, and treatment options. Overall, influencing health behavior change towards prevention, reduce burden on healthcare facilities. Economic development, we believe that when people stay healthy and enjoy high quality of life, they are generally very productive. In a nutshell, the benefits of our work at the individual, interpersonal, and community levels in addressing social determinants of health are evident. And everywhere you go, we've raised the profile of Toronto Public Health in the communities, and they love us when we walk in there. And this is why I'm here to share with you and celebrate the works that we do. Unfortunately for you who are turning your back on the screen, you're not seeing the beautiful moments that are captured in the pictures. Thank you.
Thank you, Morris. We have some of us have screens in front of us too, just by the way. Or I do. Okay.
Good morning. So the Pan Am Games were a huge success, and we should all be proud Torontonians, even with the HOV lanes. So my name's Debbie Hilton, and this is Catherine Conlon, and we were the lead public health inspectors during the Pan and Para-Pan Am Games. Toronto was the host city. The Pan Para-Pan Am Games was the largest multi-sport event ever hosted in Canada. It was estimated that Toronto would receive an additional 250,000 visitors in addition to the 10,000 athletes from the 41 Pan-American countries. My role as the Pan Para-Pan inspector started in October 2014. I worked closely with HE Pan Am manager Suzanne Litchwood. I helped to develop, coordinate, and implement a work plan that included the management of food, drinking water, and recreational water safety. Partnerships were formed with the TO 2015 Organizing Committee, the Ministry of Health and Long-Term Care, the province, and other city divisions such as the CDC. Suzanne Litchwood and I met with TO 2015 regularly to ensure that food safety practices were incorporated into their planning. An important component of public health is food safety inspections. So pre-inspections were very vital during the Pan Am Games. Pre-inspections were done weeks before the Games of most of the Pan Am venues preparing or serving food. The pre-inspections and consultations included reviewing menus, food preparations, verifying food suppliers, and the cooking processes. We also inspected the Pan Am Aquatic Center during construction, the Etobicoke Olympium, and the YMCA. So what are some of the risks associated with an event of this size, particularly with a venue like Athletes Village? This venue was open 24 hours during the Pan Am Games, serving at peak 20,000 meals a day. The volume of food is definitely a risk because this increases the chances of a foodborne illness or an outbreak. So maintaining temperatures of cooked and ready-to-eat food and food storage had to be adequate. As inspectors, we get asked a lot of questions during inspections. The most common question, it doesn't matter where we are, what type of food it is it safe? Doesn't matter if the food just came out of the oven, piping hot. As soon as they saw us with a thermometer in our hand, just about to insert it into the food, that look of dread just comes over their face, as if there's that always possibility that we will throw at that food. Is it okay? And then we will say it is. However, if there's a possibility that there's any temperature abuse at all, that food would be discarded. So I will now pass the Pan Am torch over to Catherine.
Good morning. My role with the Pan Am Games began on June 1st, 2015. Our Pan Am team consisted of 4 public health inspectors, myself and Debbie, Lumi Gregorius, and Brian Zhao. It was later reduced to myself and Debbie for the Para-Pan Am Games. Over 350 inspections were carried out at 29 sites across the city. Routine inspections were carried out at swimming pools and spas that were used for competition, at all the food venues, Athletes Village, community events, and torch relays where necessary. As well, health-related issues regarding safe drinking water, tick bites, and air quality issues were investigated. The majority of our inspections and public health inspector time, however, was focused on food safety due to the sheer numbers of meals being prepared and served for the Games. The venues ranged dramatically in size and by number of meals prepared, from our largest venue, Athletes Village, which served approximately over 400,000 meals over the Games, to some of our smaller training sites, which would only serve about 3 meals per day. And to talk a little bit about our inspection and some of our experiences during the inspection, we did encounter some temperature abuse. Some poor food handling practices and lack of food safety knowledge were observed at some of the sites. Unfortunately, we did have to condemn and dispose of some of the foods due to temperature abuse and improper handling and holding of hazardous foods. And on a personal note, some of our more personal experience, it was really, really hot working during that first never-ending heat wave of the summer, and having no access to the HOV lanes was a challenge. For the most part, however, we were able to navigate the city well, but getting back and forth to York University was a challenge, especially during rush hour. But having said all that, we would like to wrap up our presentation on a very positive note and talk about the overwhelming good. It's estimated that over 800,000 meals were served to athletes, coaches, technical officials, games workforce, games families, press, and volunteers, and not to mention the number of meals that were served to spectators during the events. There were no confirmed outbreaks or food poisonings reported. We received and investigated only 7 food-related complaints, most minor in nature and easily resolved. No major health hazard investigations or emergencies were reported during the games. No issues were identified that couldn't be dealt with effectively and immediately by the PHIs on site. We were able to collect and test a tick that bit one of the athletes to determine that there was no risk of Lyme disease transmission. And finally, we developed a very positive and effective working relationship between public health inspectors and the food caterers and Toronto 2015 Organizing Committee, allowing for the immediate, professional, and effective resolution of any problems that we identified. Thank you.
And we won a record number of gold medals, too. Yeah. Was the good food. Must have been the good food.
Good morning. My name is Dr. Kainu Zwig, and I'm honored to be representing the Mobile Dental Clinic today. The Mobile Dental Clinic is one of Toronto Public Health's 24 dental clinics. Inherent in its name, it is the one and only mobile clinic. It is essentially a redesigned 40-foot RV with 2 functional operatories and a fully functional sterilization area. Our program, we work with community agencies from an array of backgrounds, from community health centers to shelters to YWCAs and community-based volunteer groups. And our clients are marginalized individuals, including street-involved youth. The Mobile Dental Clinic has been a great addition to the Dental and Oral Health Services Division of Toronto Public Health. We've been providing dental services to the citizens of Toronto for over 3 years. The Mobile Dental Clinic has and continues to fulfill the Toronto Public Health mission of reducing health inequities and improving the health of the whole population. We do this by addressing the inequities of access, in particular to mental illness, limitations of transportation, bias, and stereotypes. I think to fully experience what we do, I'm just going to give 2 examples of the types of stories that we've encountered. One in particular that strikes, that resounds for me is a gentleman we met at Asian Court. It is a drop-in homeless shelter that this individual on first encounter was quite intoxicated and could not be treated that day. He was quite violent and abrasive. His desire was to get his denture repaired. We don't often do dentures on the bus, and this shows you how important oral health is. Eventually, this gentleman was so inspired to get on the bus that he did make a 180 and sobered up enough so that we could see him. And we did a minor denture repair that enabled him to wear this denture that he could not wear for 3 years. And we saw this individual come from such an intoxicated state to essentially a very polite and thankful gentleman. He purposely came back to thank us multiple times. And then on the screen, what you see is a testimony from another individual that we encountered at another location that we go to. This story, we have the luxury of seeing both sides of the story. Our newest member to the team actually worked there at this site. It's a family residence. It's located on Kingston Road. It is a family shelter for homeless families. She worked there previously as the early childhood educator and encountered this individual who never smiled, was very self-conscious. And from the moment that she knew that the Mobile Dental Clinic had collaborated with family residents, she came onto the bus and received full comprehensive treatment. And the member said that the moment she stepped off that bus, she was smiling ear to ear, has never stopped smiling. And if you just look at the testimony, I know some can't read it, I'll read it for you. It's quite telling from what she writes, what we actually do. She says, "I'm very grateful for the dentist bus. The work they are doing for me is amazing. It is going to give me a new confidence in my life. It's almost like a new start for me. I will be able to smile without the insecurities I have regarding my teeth. I can go to job interviews and be proud to smile without having my past show in my smile." And I think what's telling of her testimony is that a lot of our clients, they do hold their past in their mouths. And what we can do and the little that we do, even from a minor denture repair, we are doing life-changing events daily on the bus. And none of this could be possible without the exceptional staff, and because it is TPS week, I would like to acknowledge that the staff who unfortunately can't be here today because they are working at a youth shelter today. If it was not for the exceptional interpersonal skills of this amazing team, let alone that the bus reduces the barriers of access, it is the team that reduces or helps with the interpersonal skills that we are able to treat the clients that we do treat. So I commend them even though they're not here.
Thank you very much, Dr. Kainu.
Good morning. I hope you're ready for more success stories. My name is Rebecca Valiani, and I am one of the 16 registered dietitians in the Healthiest Babies Possible program, which sits within the Healthy Families Directorate in the Maternal Infant Health stream at Toronto Public Health. You can see our team in that picture. So the goal of we do provide nutrition counseling and support to pregnant women who are nutritionally at risk. Our goal is to improve pregnancy outcomes for these vulnerable women, such as gaining a healthy weight gain in pregnancy, having a healthy baby with a healthy birth weight. As dietitians, we work with these vulnerable pregnant women to improve their access to healthy and sufficient food. We provide prenatal vitamins, we provide food certificates in an amount of equivalent to about $10 per week, and we make referrals to community services that they may need. So I'd like to share some of the scenarios to give you an idea of what our daily work is like as dietitians out in the community. So I met a teen who I will call Maggie, and she was couch surfing when I met her. Because of the pregnancy, she had to leave her home, and by the time I met her, she had actually lost about 15 pounds in her 5th month of pregnancy. She was eating very poorly. So as a dietitian, part of my job is to help women realize the importance of nutrition for the growth of their baby. You know, it's all common sense. When you are pregnant, you have to eat healthy. But these women have so many different stresses, and eating healthy is not always at the top of their priorities. So I met with these women, with this girl, and we would strategize on how she could maximize the little money that she had so that she could buy healthy snacks, high-protein snacks, and do the best that she could in her situation. So Maggie started gaining weight. She improved her diet tremendously in the last couple of months of her pregnancy. I was very happy that she accepted a referral to a public health nurse. Sometimes we actually, as great as the nurses are, we need to sell the service, and the public health nurses sell our services, so we really work together, helping each other. So Maggie went on to have a healthy baby. Just to give you another example, I will call her Michaela, and she is a newcomer. A lot of our clients are newcomers. Michaela had a university degree, but both her and her partner were unemployed, they were food insecure, and she was very isolated and struggling with clinical depression. At first, she refused any referrals that I wanted to make for her, but she was very appreciative of our visits. I would meet her every 2 weeks and give her the food coupons, the prenatal vitamins. So she was very appreciative of those nutrition supports. And like many of the women in our program, these coupons did not solve their food insecurity, but it did help them to buy foods that they wouldn't buy otherwise, like fruits and vegetables and milk. So they are very appreciative of these supports. So I was very happy after a few visits when she did accept to attend a prenatal program, and she found social supports there and was connected to other Toronto Public Health services. When she had her baby, she felt a lot better, and she was linked to Parenting Progress in Toronto Public Health. So we have many stories, but I'd just like to make a mention of probably the most vulnerable women that we see, which are going to be women that are homeless and are struggling with mental health and addictions. So we serve these clients in collaboration with public health nurses from HBIC, the Healthy Babes, Healthy Children, and the HARP team, the Homeless at Risk Prenatal Program. I always feel amazed when these women show up to our appointments in spite of all the difficulties that they face every day to survive. But when we meet with them, it feels great to ensure that we give them prenatal vitamins, that we may buy a healthy snack or take them to the grocery store with the gift certificates and buy healthy foods. And the best thing is that we can sit with them and meet with them and just remind them that there's a lot that they can do in their situation to do the best for their babies. So as dietitians, you could imagine that the hard part of our work is coming face to face with all the challenges, with all the barriers that these pregnant women face day to day. But at the same time, this is the best part of our job because I feel that we can truly make a difference for these mothers and their babies. So as dietitians, we go wherever the women are. We try to decrease access. So you will see dietitians meeting with these clients at community agencies, at shelters, at coffee shops. In extreme circumstances, we may even meet them at a park in a bench. Wherever they are willing to meet us, we are there. I believe our dietitians can make a difference by providing supports, but also by building trusting relationships. This empowers the women to believe in themselves and do the best that they can to have the healthiest babies, to have the healthiest pregnancy and the healthiest baby possible within their circumstances. So we could not work in isolation. You know, their needs are very complex. So we are very lucky to work in collaboration and partnerships internally and externally. We work with public health nurses and dietitians in many streams in Toronto Public Health, and we work together with staff in shelters, community agencies, food banks, libraries, everywhere that we could advocate for our clients' needs. I feel very privileged to work at Toronto Public Health, and I just want to thank management for the support that they give us in training and skill building, because without those skills, we could not meet the needs of these clients. Thank you.
Thank you, Rebecca.
I want to thank all my colleagues who came today to share some of their day-to-day work with members of the board. I just want to add one thing. Toronto Public Health is often recognized, not just during Toronto Public Service Week, but recognized by external agencies and bodies for the work that we do. Occasionally, I will come and let the board know that we've received an award of some kind. We don't normally report on the recognition, the external recognition that individual staff receive, but there's quite a few of those, and I just wanted to share a few of them today for an example. Within the past little more than a year, Noreen Schofield from Healthy Environments received an Award of Merit for Outstanding Achievement in Public Health from the Canadian Institute of Public Health Inspectors. Our own Director, Hazel Stewart, Director of Dental and Oral Health Services, received an award at a recent conference for her work in partnering between public health and primary care. And the sexual health promotion team has been particularly recognized in the last year. 3 members of that team received awards. Anna Lee, a Community Builder Award from Ward 27. Betty Wu Lawrence, award as a leading woman and community builder from the provincial ministry responsible for women's issues. And Karen Chan, an award from Planned Parenthood of Toronto, Service Provider of the Year in 2014. So there's a lot of recognition that your staff get for the work that they do in the community. This week is just one opportunity for us to show our thanks for all of that work. Thank you very much.
And just to heap additional praise, I know that I speak for the whole board and indeed council and the people of Toronto to say thank you to our great public health staff that keep our city healthy, safe, and provide us with a good quality of life. So thank you on our behalf as well. So we'll go now on to other items. We'll start with 6.2. Green City, Why Nature Matters to Health. The Medical Officer of Health has a presentation. Over to you, Dr. McEwen.
Thank you very much, Mr. Chair. This report is part of the work that we've been doing under the rubric of Healthy Toronto by Design, exploring the science and evidence behind the relationship between the shape of the neighborhoods that we live in and the health that we experience as residents. This report shares with the board two reviews of evidence, collaborative reviews done by Toronto Public Health and by the David Suzuki Foundation, which are really filling a gap in our understanding of the relationship between green space being anything which is landscaped or natural in a city, and the health of the population in that city. Green space we talk about includes parks, ravines, schoolyards, backyards, private backyards, street trees, and landscaped open spaces on street line and along buildings. So all of that greenery makes a difference to our health, and this report really shares and assembles all of the evidence for that relationship so that it can be used by people who are making decisions about our green space. It's important that we not take the green space that we have for granted. We have quite a lot of it in Toronto, but it is under pressure. It's under pressure from changes as the city grows and becomes denser. It's under pressure from extreme weather events, often associated with climate change, and we saw that during the ice storm when there was a tremendous amount of damage done to the city's tree canopy. It's under pressure from the financial circumstances of land development. Land's very valuable in Toronto, and there are lots of uses other than green space that are competing. And it's under pressure, at least the plants themselves are under pressure from invasive pests. So you've all heard about the emerald ash borer, which is expected to take a heavy toll on Toronto's over 800,000 ash trees in the next 5 years. One of the first pieces of research that really established a relationship between green space and health was a study in 1984 that looked at the relationship between green space and patient recovery in a hospital in Pennsylvania. And in this case, the exposure to green space was just visual. It was found that patients who looked out the window and saw greenery actually recovered more quickly from their illness and from surgery. Since then, there's been quite a lot of evidence that's been amassed. The two reviews that are attached to this survey look at the scientific literature since the year 2000 and have identified the relationship between green space and physical health, mental health, air quality, which of course has an important impact on overall health, climate change, and of course, as with any policy report that we bring forward, we look at health inequities, and there's evidence about that as well. I'm just going to speak very briefly about each one of those dimensions and what the evidence says. The majority of the research that we looked at found a strong relationship between green space and physical health, and particularly green space which is close to where you live. It was particularly notable that green space close to home has the greatest benefit for physical activity and healthy weights, particularly for children. And children were found to be a population that was particularly affected by the presence of green space. Another striking finding, and one that's perhaps not as self-evident, is the relationship between green space and birth outcomes. There were significant studies which found benefits for green space for mothers who live in neighborhoods that have a lot of trees, grass, and other vegetation. They were much more likely to deliver their babies at full term and a healthy weight. So that gives everybody a better start in life. Mental health. An overwhelming majority of the studies that were reviewed found a clear relationship between mental health outcomes and green space. And you know, if you walk into the woods, as some of us do on the weekends or during the week, you can almost feel that mental health benefit in a very qualitative way. But the research suggests that it is a real phenomenon. We do see less stress, anxiety, and depression, and better self-reported well-being for people who have more access to green space. Air quality, we know, is an important determinant of health. You've had reports from Toronto Public Health before about the toll that our current levels of air pollution take on health. 1,300 premature deaths per year in our most recent study of the burden of illness, and over 3,500 hospitalizations. Well, we know that green spaces, and particularly trees, through absorption and adsorption, help us to deal with air pollutants. All of the major pollutants that are associated with health impacts can be decreased by having good green space and trees. And there have even been studies that have costed out the benefits that are accrued when we have enough green space. TD Economics has looked at the quantity of air pollution which is removed by trees in Toronto. It amounts to about 1,900 tons of air pollutants per year, which is a value of $80 million worth of environmental benefits. And the cost-benefit assessment showed that for every dollar spent on tree maintenance, between $1.35 and $3.20 in benefit was accrued in terms of health cost savings. So very important impact on air quality, which is one of our big challenges from an environmental health point of view. Now, as you've heard from us in other reports, climate change is expected to be associated with a number of negative health impacts, particularly associated with extreme weather and extreme heat. We know that trees in particular and green space generally help to mitigate the urban heat island effect and can provide a heat reduction in very green neighborhoods of between 1 and 7 degrees on average compared to non-green areas. So there are some real benefits from a climate change point of view. And lastly, the good news about green space from a health equity point of view is that those who are most disadvantaged and lowest income benefit the most from access to green space. So increasing access to green space, planting more trees is one way of reducing health inequities across the city. One of our recommendations has to do with this. So the recommendations in the report really are focused on a health perspective, on decisions made about expanding and preserving green space. The city already has some very good foundational policies in the official plan, in the parks plan, and in the strategic forest management plan, providing the resources to implement those plans, and in particular to meet our goals for tree canopy cover would be a significant health benefit to the city, and we're urging the board to ask City Council to deliver on that plan. From a health equity point of view, prioritizing investment in green spaces in the 31 neighborhood improvement areas would be a good way of addressing health inequities. And finally, we recognize there's a lot of decision-making happening around school sites, which are a valuable asset within the city in a number of different ways. This report argues that they are a valuable health asset and that that should be a part of the thinking in terms of the future of those sites across the city. Thanks very much, Mr. Chairman.
Thank you, Dr. McEwen. Before we go to questions and discussion and debate, we have two deputants. We have Mike Pudister and Pegeen Walsh. Are they here? Great. So we'll start with Mike. Just for everyone's benefit, the way the deputations work is you have 5 minutes. You might have some questions from the board as well. And I'll give you some signal when you're close to 5 minutes, just to be fair to everyone.
Thank you, Mr. Chair and members of the board, for giving us the opportunity to speak with you this morning. There are hard copies of our presentation, hopefully handed out if you wish to follow along. My name is Mike Pudister. I'm Deputy CAO of Credit Valley Conservation Authority and co-chair of EcoHealth Ontario. And joining me this morning is Pegeen Walsh, who I'm sure many of you know, Executive Director of Public Health Ontario and also co-chair of EcoHealth Ontario. We'd like to start by congratulating Toronto Public Health for taking leadership in producing this excellent report and encourage the Board of Health to fully endorse the recommendations being put to it today. I'd like to tell you a little bit about EcoHealth Ontario so that you can better understand why we think the information and ideas presented in this report are so important and the unique opportunity that they represent. We came together in a formal way in 2013. And in the hard copy, you can see that we have three key sort of purposes, if you will, for EcoHealth Ontario: developing new collaborative relationships, improving the quality of our ecosystems and access to green spaces, and restoring, protecting, and enhancing their benefits for the health and well-being of our communities through new or enhanced policies and programs. There's a summary slide that indicates sort of the breadth and depth of our membership already. We have over 160 organizations, individuals, and community groups that are part of our network. And Toronto Public Health was involved right from the get-go and have been very instrumental in helping shape the work of EcoHealth Ontario. Our partners came together because we were concerned about some very disturbing trends affecting our communities: the loss of green spaces, increasing disease, and the impacts of climate change. To tackle these trends, we realized that we need an intersectoral approach to dealing with the issues. We also saw the opportunity to capitalize on the growing evidence and awareness of the health benefits of the natural environment. And Medical Officer Health has really nicely summarized those key connections that I think we need to be continually aware of. Here in Toronto, the neighborhood ravines, woodlots, street trees, and other green spaces are critical to the quality of life of your residents. It is important that your good work and that of your partners continues and is accelerated where possible. Green space is not a luxury. It is a determinant of our health and essential for our health and well-being. I'd now like to turn it over to Pegeen Walsh.
Well, thank you, Mike. Allow me to also add my congratulations to Toronto's Medical Officer of Health and his staff for such an excellent review of the literature and series of very positive and progressive recommendations. There's no doubt that these will help contribute to furthering the health and well-being of Torontonian residents and your local natural environments. On the presentation, we looked at a number of reasons why we're very excited about these recommendations and want to see them moving forward. This review adds to our understanding of the relationship between green space and human health. It recognizes the importance of preserving, maintaining, and protecting green spaces and supports increasing Toronto's canopy cover. And in particular, we like how it's focused on improving health inequities and looking at the key role green spaces can play for those that are most vulnerable. We recognize that there's a lot of complexity around school sites, but they're such an important community asset, and there's a need to look at the health consequences of losing any of those assets. We also like how it prioritizes green space investment areas, and including parks, and putting those in those high-need neighborhoods. And the call for strengthening policies on green spaces and provincial land use planning. And this is an area where we would be pleased to lend our support in terms of advocating at the provincial level. We also like the way that the Medical Officer of Health has called for a cross-city approach, because in order to achieve these important goals, it will be important to work across the city, whether municipal planners, parks and recreation, and other divisions of the city. We recognize that there's a lot of pressure on city budgets and makes it very hard as you are faced with making priorities and choices. But we ask that you think of green infrastructure as just as important as the other infrastructure in the city. The Medical Officer of Health talked about the urgency and the pressures that green spaces are facing. So again, we just want to emphasize that the very progressive and positive recommendations, and we look forward to working with the city in ways that we can help move these recommendations forward. Thank you.
Great, thank you very much for your presentation. Are there any questions from the Board of Health to the deputants? Great, thank you very much. Thanks for coming. We'll take it into the board now and invite board members to ask any questions of staff. Councillor Nunziata.
Yes, just on recommendation 5, if you can just clarify. To ensure that any green space, open space, and sports facilities associated with school remain accessible for use by the public. So on that recommendation, you're referring to some of the new schools that are being built, that they retain green space rather than cement their play area, which has been done over the years. That's what you're referring to, right?
Yes, we realize there's a lot of pressure on both school boards and municipalities in terms of how these school spaces are dealt with if they're no longer needed for schools. What we're really saying is that as those decisions are made, let's try and preserve as much green space as we can because of the benefits to health.
Yeah, so all the new schools that are being built, rather than the playground be cemented, that you're recommending that they have green space for a play area for the new schools.
Absolutely, and for schools that are no longer needed for educational purposes and which may be sold for development, let's see if we can have some green space in that development as well, so we don't lose it entirely.
Parquet, or, yeah. On recommendation 5, I think it'd be appropriate to send this recommendation to the school advisory committee that the city has, which Councillor Doucette and I are a member of it, so to forward it on to that. Actually, we have a meeting on Friday, so I think that would be appropriate. Okay.
The whole report.
So I'll amend that, yeah.
Okay, great. Any other questions? Okay, to speak, Councillor Nunziata, do you want to get your
I'll move an amendment to recommendation 5.
how about the whole report? Just
Well, actually, just for the whole report to the school advisory committee, which we're meeting this Friday. So if we can forward the report on.
Okay, any other speakers? Councillor Carmichael Greb and then Councillor Doucette.
I just wanted to also just flag the importance of recommendation number 5 in my area. The TDSB has been fighting our local community at the OMB to sever and sell off green space that's part of a school. Over 600 children in the community use it on a daily basis for soccer, t-ball, and it's it has been approved by the OMB to sever, so hopefully the TDSB will come to their senses a bit and retain the space for a bit longer so that it can continue to be used by the community rather than putting 18 homes on it.
Thank you. Councillor Doucette?
I want to thank staff. I think this is a great report. You know I'm always out there looking for more green space, more trees, more environmentally friendly, and lots of places for kids to go and get off the couch and go and have fun and exercise. One of the things which sort of jumped to me, we're talking about, on page 9, you're talking about indoor plants. I had a young gentleman in one of my high schools who actually started a group called One Plant. And what he wanted was every classroom to have one plant in the classroom, because he had found through research that even having one plant made a difference to the kids' learning ability. He even did a presentation to the Toronto District School Board, who, with our school trustee at that point was Irene Atkinson, thought it was a brilliant idea. He's now in university, so I don't think it's gone any further, but he got a lot of schools in my area to do that one plant. Something like that I thought was a great idea, and I'd love to see more initiatives like that. Community gardens. I love community gardens. I'm still battling to get mine up and running. That fits in so beautifully with our poverty reduction when we're saying that people should have access to somewhere to grow food. So this whole report is absolutely wonderful. We also mentioned that the parks plan is great moving forward. The sad thing is there's no budget for the parks plan. So we need to make sure as councillors and as residents, we start putting a bit of pressure saying, you've got a plan, it's excellent, it's great, but you need to fund it. We need to be protecting our green spaces. As we hear, all school boards are having pressure with their schools. Some of them are having to sell off their property. City doesn't have the financial ways to buy these properties, but we should definitely work with the developer to make sure we do have green space. So I just want to say, as I say, I think the report is great. Lots of wonderful ideas. Let's go plant more trees. Let's get more community gardens going. And let's get our kids off those couches of theirs, out there playing soccer, frisbee. Could be skating on Grenadier Pond next winter. And gardening in general. I use gardening as my relaxation. I'm very fortunate I have a small garden, and when I've done city council or city meetings, that's where you'll find me, pulling the weeds in frustration. Some of my plants suffer a little bit, they get a bit more trimmed than they would have, but basically, thank you for the report. I think it's wonderful, and I'm glad we're adding the amendment to send it to the school advisor. I think that's a brilliant idea. Thank you.
Thank you, Councillor Doucette. Any others? I'll just put on a motion from Trustee Chris Glover, who sent an email. I see he's not here. His motion basically puts the city council in the picture and also asks the funding question. And it's not my motion, but I'll try to speak to it in a supportive way. The issue really for the TDSB, and he said it in his letter to me just supporting this motion, is that the school board does not get funding, enough funding basically to be able to provide the lands for a reasonable price to the city. And so that's probably the elephant in the room around converting school sites to public open space, is the lack of budgeting either from City Hall, which we're totally sympathetic towards, but also from the province. They want full market value at highest and best use. And so I think he's alerting us to the critical need to solve the funding issues as school boards sell some of their properties. So I think they're supportable motions. Okay, so
I have a question on the motion to Trustee Glover through you.
Okay.
He's not, it's just, if it's appropriate, I think the motion is the spirit of the motion is correct, although the way in which he has worded it, the Minister of Education and City Council, it is for us to provide funds. And that's not exactly what he intended. Given that this motion from the Board of Health is City Council receives it anyway, I would delete and City Council, because the way in which it's written now, it is saying that the Minister of Education and City Council should provide funds. And that's not the spirit of, I believe, what Trustee Glover probably intended. If he was here, I would say that's a friendly amendment. But he's not.
Not here, okay. Sorry?
The funding's already in Rec 1 as well.
That's for trees only, yeah. Okay, I think he probably meant that he does want city council to, because when we take them into public hands, they usually sell them to, if it becomes green space, we buy them as City Hall. So we're not, I think we're looking for a discount. I don't think we're looking for, frankly, if the province just gave us the land, that would be great. That ain't gonna happen. So, and I know that Parks and Rec staff are actually working on strategies to, from cash in lieu of parkland from developments, to use some of that money for the purchase of the sites. But the quantums are so large, these sites, like I'm sure in Councillor Carmichael Greb's ward, the money is so huge that it puts a big strain on our budget. And that's because it's highest and best use. And if you're gonna separate it out and have 18 units, those are big bucks. So I think the city is willing to pay something, but it isn't willing to pay, frankly, we can't do market value, and that's where the province has to come in a supportive way. So I don't know. You can vote as you wish. Maybe I'll take it separately, but I think he put it forward. I think he knew what he was doing. Okay.
While I have some concerns regarding the specific wording, I think the intent is fine, and I'll be supporting it.
Very consensus building of you. Thank you. Okay, so we have a motion from Councillor Nunziata to forward the report to the City School Boards Advisory Committee. We have a motion from Trustee Glover. He's not here, so anybody can take, Councillor Cressy can take carriage of it. And we have the main motion. Do we need to separate them out? Yes, okay. Okay, so we'll start with Councillor Nunziata's motion. All in favor of additionally sending it there? That carries unanimously. Councillor Cressy's motion on behalf of Trustee Glover. All in support? Opposed? 1, 2, 3. Okay, that passes. Oh, sorry, 4. Sorry, let's do that again. All in favor? Put your hands up. 1, 2, 3, 4, 5, 6. Okay, I think. And otherwise minded? Opposed? 1, 2, 3, 4, 5. Okay, I think that passes narrowly, but it does pass. And then the item as amended. All in favor? Opposed, if any? That carries. Okay, thank you very much for this good work. Moving on to, well, seeing we have the, do you want to do the works? Okay, great. So we're on 6.3, the Works 25th anniversary. The Medical Officer of Health has an additional presentation on this matter. Dr. McEwen.
Thanks, Mr. Chair. This presentation really serves to introduce both this item as well as the next one, the report on overdose trends and prevention in Toronto. I thought, since we are reporting on overdoses, which is one of the major harms associated with drug use in Toronto, and this is the first time we've reported in some time, I think, on overdoses. It's a very important topic. It was a good opportunity to highlight some of the work that we've been doing around harm reduction. So I'm going to talk a little bit about the WORKS, which is Toronto Public Health's harm reduction program, and it happens to be, we've just recently celebrated the 25th anniversary of this program, which was at the time and continues to be a groundbreaking program. I just want to point out that Sean Hopkins, the manager of the WORKS, is here today with us. Some of you know her. The WORKS, as I said, is Toronto Public Health's harm reduction program for people who use drugs. Harm reduction, of course, is one of the 4 pillars of the Toronto drug strategy, the others being prevention, enforcement, and treatment. The WORKS currently offers multiple services associated with harm reduction, the distribution of supplies, predominantly injection and smoking supplies, needle exchange, offers counseling and support for users, education awareness, There is a peer component program in which people who have been drug users deliver services to those who are currently using. I'm going to talk a little bit about the POINT program, overdose prevention, because it's particularly relevant to the report on overdose trends. We also offer a methadone program, which is an opioid substitution therapy. We do testing for infectious diseases associated with drug use. We provide immunization for those diseases. And of course, we provide a wide range of referrals for other services that drug users may need. The Works has been going for 25 years now. It's currently based at 277 Victoria Street. That's the fixed site where most of the services are offered. It also has a mobile service which operates in the evening, 6 days a week. We have, in addition, extended the harm reduction services through arrangements and partnerships with 50 different community agencies who see drug users in their normal work, who are able, through our partnership, to provide them with harm reduction supplies and education. So there's a very comprehensive outreach component to reach drug users in the city, who are not always an easy group to reach compared to other populations that we provide service to. The Works was originally established in 1989, which was really at the height of concerns about the AIDS epidemic, and this was one of the key interventions of Toronto Public Health to address HIV transmission through drug use. And around the world at that time, many cities had seen alarming increases in their rates of HIV infection among drug users. In fact, in some parts of the world, the HIV epidemic, such as Russia, was driven largely by injection drug use. And needle exchange had just emerged as a new approach to prevent transmission through dirty needles, reusing needles from one drug user to another, which is the transmission of viral infection, particularly HIV, but of course also an important mode of transmission for hepatitis. So in that context, Toronto really took the lead in establishing early on a needle exchange program, which has played a key role, we believe, in having Toronto have one of the lower rates of HIV infection among injection drug users of major cities around the world, and we continue to run at lower rates than many other cities. It also served a purpose in preventing the discarding of used needles. Needles are taken in at the same time as they're given out, and that helps keep dirty needles off the street. Over time, other services have been added to meet the needs of this particular population, and additional harm reduction services are part of that. And the one that I want to highlight today is POINT, Preventing Overdose in Toronto, which is a program which distributes an injectable drug called naloxone, which acts as an antidote to the adverse effects of opioid drugs like heroin, OxyContin, which, if taken in overdose, depress respiration and can lead to death, essentially. Naloxone is a drug which has very few risks. If injected at the time of an overdose, it essentially reverses the physiologic effect of respiratory and cardiac depression and essentially wakes people up who are unconscious. It's quite a dramatic thing that happens when it's used. We had noticed in 2011 that there were programs beginning to be developed in other parts of the world which actually gave naloxone training and kits with the drug to people who were likely to be on site when a drug overdose happened. So those are users, family members, and friends, people who are likely to be in the room or in the apartment when someone becomes unconscious from an overdose. Getting the naloxone into the person as quickly as possible is key. What we train people to do is to give the drug and call 911. So that help can arrive and the person can be transported for more definitive care. So far, we've trained and distributed kits to about 2,000 people, and we've recorded 300 instances in which these kits have been used in an overdose situation. Not possible to say how many of those people would have died, but I think it's a fair bet to say that the intervention with naloxone was probably definitive and life-saving in many of those cases. This has been a very successful program so far, and one that has been emulated in other jurisdictions, something that we'd like to see made more broadly available across Ontario and across Canada. Over the past 25 years, the Works has been a leader in many different areas. It was the first needle exchange program in Ontario when it started. It is still the only public health agency-operated methadone program in Canada. It was the first public health agency to operate this take-home naloxone program nationally, POINT. As I said, our rate of HIV continues to be lower than many large comparable cities. We see about 85,000 services to the works and all of the partner agencies each year. Last data we have is for 2014. And we distribute at this point about 1.3 million needles to people who inject drugs in Toronto. The goal in terms of interrupting the transmission of communicable disease by needle sharing is that every time a person takes a drug, they will have a clean needle at hand. So it's very important to have a sufficient number of needles in people's hands for that to happen. Now, this is a harm reduction program, so it's targeted at the harms associated with drug use, but through referral, we do refer people to treatment services and offer the opportunity for people to deal with the underlying challenge of their drug use. In the meantime, we want to keep them alive and uninfected until they have a chance to get off drugs. So this has been, I think, a leading program, a very successful program, and continues to play a very important role in addressing the harms associated with drug use in Toronto, including overdose prevention, which is the subject of the next report. Thanks, Mr. Chair.
Great, thank you very much, Dr. McEwen. The following two reports, 6.4 and 6.5, there are no presentations there.
There aren't, but I failed to do the last thing in my presentation, and that was to say that we're going to show you a short video.
Okay.
We made a video on the occasion of the 25th anniversary of the works to record some of the users and clients and staff's views about the difference that the program had made. So we've got an edited excerpt from that. We didn't want to show you the whole video. If anyone's interested in seeing the whole video, we're happy to make it available. But we have a short excerpt of it that will give you a sense of the impact that the program has had from the point of view of users and volunteers and staff.
Great, thank you. Question, yeah?
Are you offering tours of the works for the new system members?
Yes, we have. Certainly when people join the board, I routinely offer an opportunity to see some of our programs in action, and that's one of the ones that I think is very interesting for board members to see, because you'll see some very challenging client relationships, some very challenging health issues that we're dealing with, and a part of the city that you may not have seen before.
Great, wonderful. Okay, are you ready? Okay.
Toronto's Fast Rock on the 6 o'clock Rock Report.
It's supper time, and the Needle Exchange Mobile is heading west on Queen Street into Parkdale. On a typical day, the counselors might meet as many as 50 people and exchange some 30 needles. They also distribute free condoms and needle cleaning kits. Fred Ruff manages Toronto's Needle Exchange.
We are in the business of AIDS prevention, and the injection drug user is at extremely high risk. It's a direct blood-to-blood transmission of the AIDS virus if a person is infected.
Harm reduction, harm reduction, and harm reduction. That's a basic public health principle. And so our aim was to reduce the likelihood of that AIDS virus being transmitted in the injection drug using population. At the same time, promote safe sex. At the same time, educate that population on how to prevent the transmission of the AIDS virus. Well, we knew from the data, we knew from the evidence that the AIDS virus was progressing rapidly into the injection drug users population. And so we knew we had to get to that population because they were not part of the mainstream of society. And that was really the driving force. The injection drug using population, I think, were very receptive, obviously. The political community, council, there was some reluctance. There was some significant opposition. And lastly, the police community. That was the biggest sell. That was the hardest sell. Because when I did the research in Amsterdam and I saw a Toronto Star, which prominently featured a comment from Jack Marks, the then chief of police, who was not going to support a needle exchange. So the big challenge for me when I came back to Toronto was to sell him on the idea, and after a long, tense meeting, he bought into this program. His condition was that the public health department runs the program.
I think there was a real concern in 1988 when the program was starting to be thought about, and 89 when we implemented the program, it was approved through City Council. I think there was a lot of concern that there would be a huge increase in HIV for people who use drugs in the City of Toronto.
There were a lot of community meetings around the time, and there would be a lot of objection to the works. Objection to needle exchange, objection, but I think those objections were really coming from a moral place. You know, drugs are bad, people who use drugs are bad. And there was all these fears, you know, that if you open up a place that there'll be all these drug users hanging around outside, or if you open up a methadone clinic, suddenly your whole neighborhood will be full of methadone clients, or unfounded fears that really never really occurred. They didn't happen. You know, or we were going to increase the amount of people injecting drugs, well, which is a ridiculous argument, but there it is.
The POINT program is the only overdose response program right now in the city. Often EMS or emergency services don't get there in time for overdoses. It's important that the people at the scene where somebody has overdosed is a first responder, and they can attend, and they can treat the overdose. Overdoses are very unforgiving. They can happen very rapidly, and they're insidious. It just looks like somebody's going to sleep. There were many groups or entities that really needed to be involved, and so it took many months, if I dare say, and there was no clear-cut funding. So it was kind of a MacGyver program that was created.
Drug users, me mainly, I lived with a lot of stigma for a lot of years, you know, and I hadn't sought help, I hadn't sought rehabilitation or anything like that. I really thought that once you go into a place like that, it follows you around for life. And it was actually a friend who introduced me to the works, and we were running around on the street and we needed some clean supplies, and he said, I know a place. And I'm like, I'm gonna wait around the corner, I'm gonna wait out back. And he went in and he came out and he handed me a kit, and I just thought, what is this? This is amazing. What is this? I threw away my pop can, I threw away all my dirty supplies. Like, I thought it was just amazing. And then it took me a few more times before I actually came through the door. And then it opened my eyes. I realized there were services. I realized there were a whole group of people working to make this place possible. It wasn't just distribution or collection of needles. There's all the way from, there's a support network from students to counselors to the doctor to the nurses to the supervisors and managers, and they'll hear you and they won't judge you. And I think that's why it makes it important to users, is really the broad acceptance. I think it's not that I don't struggle every day. Oscar Wilde said, I can resist anything except temptation. And I think the works has helped me dramatically to resist that.
The fact that in spite of all the challenges that people face, that they come in, they get their supplies, they use them the way that they need to be used, and they bring the used supplies back. It's really amazing, you know? So that's the one thing that always kind of surprises me. I'm so impressed by the people who use our services.
Okay, we're good? Okay, thank you very much. That was an inspirational video. So on 6.3, are there any additional questions to staff on that? Is more informative, Dr. Peter?
Peter Wong. Great presentation and a wonderful project. I was just wondering if community engagement was involved in actually developing the process, and community engagement, the clients are involved in the evaluation of the process.
The answer is yes. We're very engaged with the community. I'll let Sean speak to it in more detail.
Thank you. So yes, our clients are involved in our program. We have a client advisory committee. We're actually just embarking on an evaluation of our program to determine where we're going to go in the future, and that will involve clients and staff and the community agencies that we work with. As you saw in the presentation, there are 50 community agencies under contract with us, and they meet quarterly with us to advise on our program and provide feedback about what we need to do.
Great, thank you. Any other questions? Just on 6.3, we'll talk further 6.4. Any speakers? Okay, all in favor of just receiving the presentation, opposed if any, that's carried. So we'll go on to 6.4, overdose in Toronto, trends, prevention, and response. We do have a number of deputants there. And 6.5 is fentanyl patch for patch policy legislation. Seeing that there are two deputants on both, I'm going to assume you're Dennis. Yes, okay. Can you speak to both at the same time? And Susan, can you speak to both at the same time? If you need more time, we'll give you some more minutes. Great. Okay, great. So we'll hear the deputants for both items, voting, of course, on them separately. First, on overdose in Toronto trends, prevention, and response, we have Donna May, followed by Dennis Long. Donna May? Oh, is this Donna? Yes. Welcome, Donna. Yeah, no problem, no problem. Welcome, Donna.
Many in the room know me as the mother of a deceased addict, and I use that experience to bring about awareness of how our policy should reflect us as a city. I'm here to discuss my daughter and my experiences with her addiction. And I'm not here to discuss what happened to her and me through that. I'm here to discuss what's happened since, and I'm ashamed. Simply put, very little has happened. Things haven't moved quick enough to save the lives of my ever-growing group of mums and dads who have lost children to substance use. And I'm not talking about, I'm not necessarily talking about hardcore addiction, and I know that that doesn't resonate well in the ears of some of my peers here. My daughter was a hardcore addict. Now I'm seeing people join me on my crusade whose child may have used a substance for the very first time. They may have been in recovery and then gone back and used again and overdosed. All these things, I'm mad. I'm really mad that this has happened because it's unnecessary. It does not have to happen. With the implementation of naloxone being provided to me and other parents and peers and family and friends, we could have saved so many of these lives. I have spent the last 3 years advocating at a federal, provincial, and community level to bring about this awareness, to raise this awareness and to provide other options, a different approach to substance use. Right now, it's based on the moral failings of drug users. We're the ones who have failed. It's our morals that have failed. Whatever happened to keeping your neighbor, being your neighbor's keeper? If my neighbor fell down and broke his leg in the walkway, I'm sure as the heck going to call 911. I'm going to go and assist them. I'd do CPR if they were dying of a cardiac arrest. But I didn't have the tool that would have saved my daughter's life. And the doctor that was in the ER room wasn't trained in overdose response and did not use naloxone. 3 years of working at all 3 levels and knocking on doors, and Mr. Cressy will know I don't shut up, but I've accomplished very little. And today I'm here asking for your help. I can't keep this up, and I cannot keep all of the other parents from showing up on your doorstep. I don't want to keep them from showing up on your doorstep. We need to implement change in our community now. We have to be a leader, a forerunner. We have to recognize that there are changes that could have and should have been made and have not, and put them into place as soon as possible. It used to be that I would be representing people that that were very visible in their addiction. I'm not doing that anymore. I'm representing each and every one of you and each and every one of your children or grandchildren, neighbors, students. There is no need for this. We're killing people. We literally are killing people by not doing things to save their lives. Naloxone works. I have a kit. I had to use an opiate in order to be able to receive that kit, and I had to sign away that I had used an opiate in order to receive that kit. That's wrong. I've been stigmatized from the day I found out that my daughter was an addict. That just further stigmatized me. I want naloxone in the medicine cabinets of each and every home, just in case, because I said no to my daughter. It didn't work. And it doesn't work. And that's been proven by the many parents that have joined me. It's not that we misled our children or failed to parent them correctly. I'm running out of time, so I'll hurry up. We didn't do that. But what we didn't do was look at the underlying issues of what caused them to turn to substances in the first place. I think I've made all my asks, and I hope that you've heard me. 3 years has accomplished very little, and that can change overnight. I'm asking you for that. Thank you.
Thank you. We have questions. We have questions there, Donna. If you
Hopefully I can answer.
you'll get additional speaking time with those questions. Councillor Doucette,
Thank you.
and then Councillor Cressy.
Thank you for coming and speaking to us today. I just want to make sure we get your asking points.
Okay.
Could you just tell us I know you say we haven't done enough, but what are you asking us to do?
I am asking you to help us move the federal government on their policy of taking another 18 months to study the use of naloxone. I'm asking you, if it's necessary, will you please overstep our federal Minister of Health and provide naloxone, or make naloxone available to all parents? I'm asking you to do as our mayor of Montreal has done and open safe injection sites. Just do it anyway. I'm asking you to fight for legislation that will provide Good Samaritan laws that do not criminalize those who are willing to call 911 in case of an overdose. I have personally heard my daughter say that she has witnessed over 10 overdose deaths where 911 was not called, and they put the body either on the sidewalk or in the driveway. And I have 3 peers who have lost their child because somebody was not able to call 911.
Thank you very much. I appreciate you highlighting those for us. Thank you.
Thank you.
Councillor Cressy.
Thank you, Donna. I'll be brief because you answered a number of the questions there. First of all, I would say that you have accomplished a great deal, you and the mothers and fathers you work with. And as a city that aspires to be our brothers and sisters, our neighbors' keepers, to your point, I think the report in front of us is hoping to do that. Did you review the recommendations in the report that spoke specifically to increasing access to naloxone and the Good Samaritan laws?
Yes, I did.
Okay. And you're supportive of those?
I am completely in support of the whole report,
Okay.
other than the fact that I don't believe that it has covered the number of people affected in total.
Okay. Thank you, Don. Appreciate it.
Thank you very much, Councillor Cressy. Councillor Burnside.
Oops, hello. I just have a couple questions, if you don't mind.
I'm sorry.
I'm over here.
I'm sorry.
That's okay. When you said people were unable to call 911, what did you mean by that?
They won't call 911 because they're afraid of being criminalized. Quite often, when police are present at a 911 call for an overdose, they are looking for the drugs, they are looking to lay charges. It's their mandate. I understand that. That's what needs to change. The legislation needs to change so that police are not required to either be present unless they're asked for by EMS specifically because they feel in danger. And when they are present, I believe that we have to turn a blind eye to what is there in order for those people that are present to even make that phone call.
So, as a former police officer, I didn't actually deal with overdose deaths, but I did with overdose situations. And so I'm just trying to understand what the practice is in certain areas, because where we were, it wasn't.
May I ask where you were?
54 Division and 53 Division.
In what area?
Young Eglinton, Flemington Park, Thorncliffe. Yeah. So, and this is going back a number of years, so things may have changed, and I'm just trying to understand. I personally was never looking to lay charges, and never did, in fact. It was getting the person to the hospital. So is this a perception, or is it a reality? I'm just trying to understand, not trying to.
It could very well be a perception in certain areas. I agree. But that perception is killing people.
Oh, absolutely, but I'm just trying to understand what the best approach is. So,
The best approach is for substance users to know that they are not going to be charged criminally if they are present and call 911 during an overdose.
Okay. And then you also talked about we haven't done a very good job of addressing the underlying issues.
That's true.
What do you mean by that?
I don't think that we have the number and the array of services for people who are addicted. And I know this from my personal experience trying to get my daughter help. Psychiatric care, she was home with me for 6 months before she died. And we asked for psychiatric care at the beginning of those 6 months, and I got the call for psychiatric care the day after she died. And that's having gone through many doctors and many hospitals and professionals to get that help. I don't think, I want to address the Patch for Patch program, which I wasn't going to touch on. But when you take a substance away from somebody, and we saw this with the OxyContin issue when we made it tamper resistant, you take something that somebody is already addicted to away from them, they're going to move on to something else that will fill that need. They could no longer easily use the OxyContin, so they turned to heroin and fentanyl. That's why we have the fentanyl problem here today. You take the fentanyl patch away from them, and who are you making rich? You're making illicit substance users rich. And I was overwhelmed with surprise at the fact that I could get the recipe and I could purchase the chemicals involved in manufacturing fentanyl. And it wasn't going to cost me very much. So what good would a Patch for Patch program do except turn people to street-cooked fentanyl and have them using something that we have no regulation over? We have no idea the amount of fentanyl they're getting within their injection or their tablet or however it's put. I have two young girls who overdosed on fentanyl that was laced into their marijuana. Like, we are creating more problems than we're solving.
All right. Okay. Okay, thank you. Appreciate that.
before I make a quick exit again.
Thank you. I think that's it, Donna. Thank you very much for your comments. Next, we have Dennis Long, member, Toronto Drug Strategy Implementation Panel. And you're also going to speak to the fentanyl patch-for-patch policy.
I'm going to try to do better than the previous speaker, which I think is an impossible job. Yes, my name is Dennis Long. I'm a member of the panel, and I'm also the Executive Director of Breakaway Addiction Services in Toronto, partner agency with the City of Toronto. We operate a full-service methadone clinic amongst a number of other programs, including an opiate outreach program. What I want to talk about this morning is the inadequacy of our responses, which to date, and I think that this report, if implemented, would go a long ways to filling some of the gaps, not all, in our response to overdose. Overdose in this city is a crisis, and we are not doing enough to counter the crisis. It's a slow-moving crisis. It's been going on now for 5 to 6 years at least, probably a little bit longer than that. In our clinic, we are in touch with the community that surrounds our clients. A large community of drug-using individuals. Normally, what we would see in a year, 3 or so years ago, would be 1 to maybe 2 overdoses a year. Now it's in excess of 3. And that's anecdotal, but I think it takes not a lot of thought to think, well, okay, if it's doubled in our clinic, that's significant. And some data that now are coming from other jurisdictions indicate in the youth program, youth demographic, which are largely new to opiate use. Opiate overdoses are now the second leading cause of death, second to accidental death, and sometimes only a little bit ahead of suicide. Young people don't die from much else, but that really indicates the spread of opiate use in demographics. We used to only treat people in their 30s. And now we're beginning to see people in their late teens, early 20s as a growing group that come to us. And they are susceptible because many of them, as the previous speaker, started with prescription drugs. And in most cases started with OxyContin. And what happened was, well, we fixed that problem. We said, okay, you can't mess with OxyContin and make it into an abuse drug. And so people migrated. They went to fentanyl, a much more dangerous drug with a very significantly smaller margin of error, and heroin and other street opiates, which are not manufactured by drug companies and have poor quality control. So we ended up with an increase in overdoses that has been growing. Why have we been so slow in responding? My contention would be, and I think I'm in sync with the previous speaker, largely because of the stigma on drug users. And I was struck when I was watching the little video of headlines saying junkies. Well, you might not be able to get away with it today in a paper, but it sure as hell is available out there on the street and in the general public's perception. I just, 3 years ago, opened a methadone clinic in a residential area. Trust me, stigma is alive and well and doing well. And often the people's opinion towards this, in the immortal words of Shel Silverstein, what's one more junkie, more or less? When people die, they don't really care. And they think of it as this stigmatized population, which also comes from a profound misunderstanding of the mechanisms of addiction. Well, look, if we make it hard to get this stuff, people will say, okay, I'm done, and they'll stop. Well, it doesn't work that way. When someone comes into a methadone program, if they don't stay longer than 3 years, their chances of success are remarkably diminished. We expect people to stay in the program 5 to 7 years in order to be successful in recovery. You don't walk away from an addiction because you decide to one day. It is a long, difficult process marked by relapses. We need to protect people from opiates during those processes. The report, I think, is excellent. I think it does it presents a number of options. It is way too difficult to get naloxone right now.
I can have my clients with naloxone. It's very difficult for me to have my staff have naloxone, particularly those who are working on outreach basis, working with people in their apartments and on the street. That's got to change. The safe injection site, the data that's coming from Vancouver, or safer injection site, sorry, or supervised injection site, is remarkable. People don't die in those facilities. Overdoses are prevented. We don't have one, and we really need one. Probably we need more than one. The Good Samaritan law, I think the previous speaker really talked quite effectively to that. I would certainly support that. The one point that I want to make, which I think is really important, is the current way of administering naloxone is cumbersome and difficult. And often we're asking people who are not necessarily in the best state of mind in an emergency situation to do something like this. Break open an ampule, fill a syringe, find a place to stick the syringe and stick it in. Now, if I have a severe allergy and I go into anaphylactic shock, I can buy an EpiPen, which through clothing I can, and it's done. Why can't we do that? Because it would be remarkably easier to do. I go back to my initial point. This is a crisis. This is not something that we can sit around like the federal government does and study for the next 18, 19 months. It's been going on for a long time. People are dying, and they are going to continue to die unless we do something. Just to touch on the issue of the fentanyl replacement patch, I've been working, when I was preparing for this presentation, I was doing the math. I've been working in addictions and thinking about addictions and teaching addictions for about 34 years now. And one of the things I know and can prove quite clearly is supply reduction as a way of reducing the damages of drugs doesn't work very well. In fact, has been largely ineffective. And that's what we're doing by this patch per patch program. So I'm suggesting severe caution in doing this. If, as the previous speaker said, we reduce the supply of prescription fentanyl, then people will make it themselves, or they will go to buy street drugs, heroin or whatever, which is significantly more dangerous. So we need to, if we're going to do this, we need to pair that with the increased availability of replacement drug therapy, which is the therapy that we know works effectively. And we do not have enough of it. And we do not have enough support for people in replacement therapy in order to rearrange their lives and recover from their addiction. All of those things need to happen, and they need to happen something like yesterday. Thank you.
Thank you very much. Any questions of Dennis? Councillor Cressy?
Just wanted to follow up, Dennis, and thank you for coming on naloxone. You mentioned that access is an issue, and that it's difficult for your staff to access. Could you expand on the challenges related to access and what you mean in terms of your staff and their inability?
Yeah, the way it works right now, as I understand it, I mean, well, I know, is that it has to be prescribed to the individual who carries the kit. That individual has to be a user. And as you heard from the previous speaker, she had to go and take an opiate and say, well, yeah, I've used an opiate, and then it gets prescribed. Well, this is cumbersome, to say the very least, and it doesn't get it into the hands of people who are often on site when it's needed. And also, even if you are a member of the drug-using community, to go and ask for a prescription is stigmatizing in and of itself. And that's often a problem as well. So what we need to do, and I think that I would agree completely with Donna, is make this something that is easily available to anyone who's working in this field or who's associating with people who may have an issue with overdose, because we know it works effectively. The only caution I would put in there is that you can't just hand somebody something and say, here, this will fix it, without good training, because technically, the half-life of naloxone is significantly shorter than that of heroin. So what happens is if you give somebody naloxone, they'll look perfectly healthy and normal, and they'll be walking around. But if the effects of the heroin goes, or opiate goes longer, the overdose could kick back in again. So they need to go to a hospital and be treated medically. But that kind of training needs to go with it.
So from the point of view of overdose prevention in this report and the recommendations, increasing access and increasing training of naloxone will seek to prevent.
Absolutely. And it's kind of stupid right now because it's just, we have a life-saving thing and we just can't use it well.
Thank you, Dennis.
Thank you very much once again. Our next speaker is Gary Thompson. Oh, did you have questions? No? Okay. Gary?
Good morning.
Good morning. Welcome. Nice to see you, Gary. You have 5 minutes.
Yeah. Okay, I read the report, and to comment on Donna's daughter who's lost her life, the doctor didn't know what to do. Well, it's simple first aid knowledge. Give respiratory assist. You can keep the patient alive indefinitely if naloxone's not available. And the medical officer's health recommendations, number 3, the quote, action on overdose prevention and response. I read the report, it's good, and naloxone's a good medication if it's used properly. A few interesting lines from page 1 of the Prescription for Life. Paragraph 4, begin to provide similar levels of care that are dedicated to reducing other preventable deaths. Middle of paragraph 5, as Peterborough Police Chief Murray Rod noted when speaking of opioid overdose and naloxone, it could be anyone's mother or father, anyone's brother or sister. We have to respond appropriately. Bottom of first page, for the same reason that epinephrine, EpiPen is. It is emergency medicine of choice and a proven lifesaver. EpiPen would not, nor should it be on the market if responders to allergy bee sting were being taught to give patient EpiPen and chest compressions only. Medical profession would be sued malfeasance. Phone Michael Parkinson, co-author of this report, June 4th. His quote, Gary, as you see, we did not mention anything about resuscitation in the report. Responded, Michael, what about the hyperlinks to contraindicated naloxone protocols? Gary, I'm late for a meeting, have to go, goodbye. Strange thing about Appendix A, the background reference to this item, the general public has access to a lot more information that has been left out of the Board of Health reference. See the blue tab on your handout? That's my response to the Board of Health, to the Prescription for Life. It's a wonderful thing to teach people to save lives. Unfortunately, Public Health Ontario is teaching the general public all the signs and symptoms of respiratory emergency, then telling them to give chest compressions only. Layperson is eager to follow doctors and nurses' instructions, believing they are saving lives. Doctors and paramedics may have a hard time distinguishing the cause of respiratory emergency, but know straight away it's a respiratory emergency, not a cardiac arrest. The signs and symptoms are completely different. Dr. Gabor Mate, quote, Toronto, June 6th. Vancouver, 2004, the RCMP tried to stop a resuscitation program for overdose. Dr. Gabor Mate taught the RCMP some wisdom. Not only will these disenfranchised save OD patients, but anyone else that suffers a respiratory emergency. the program was allowed to continue. In Ontario, public health is teaching tens of thousands not only how to increase morbidity and mortality to drug OD, but anyone else that suffers a respiratory emergency. All medical consensus for opioid OD found your red tab. This information is just basic first aid knowledge, plain common sense, respiratory emergencies. All doctors and nurses will give rescue breathing, then naloxone, then continue rescue breathing to family or friends. Children suffer respiratory emergencies. They are too young to have cardiac problems generally. Not placing blame, change this protocol for the well-being of all. Stop making yourselves victims and everyone else. Thank you.
Thank you very much, Gary. We appreciate your comments. Are there any questions of Gary? Okay, seeing none, we'll go on to our next speaker. Thank you very much, Gary. Mary K. McVicker, Program Coordinator, Street Health. Mary. Followed by Susan Gapta.
You left your computer. Excuse me, Gary? You left your computer. Sorry, Mary Kay couldn't be here, so she sent me in her place.
Great. You'll give you.
My name is Jessica Slotnick, and I'm a mental health and harm reduction worker at Street Health. Street Health is a small community-based agency providing nursing care, mental health supports, identification services, harm reduction programming in the downtown east area of Toronto. We are one of the partner agencies with The Works. We are located in the corner of Dundas East in Sherbourne, which is one of the highest rates of drug users in the city. I'm here today to share our suggestions for effective responses for the increased occurrences of opiate use and the unfortunate overdose deaths in our community. Street Health would like to see a system in place that would allow a community-based agencies such as ourselves to receive a medical directive for the administration of naloxone. Our own experiences of obtaining a directive has been frustrating and lengthy and is in fact still in progress. Perhaps the Chief Medical Health Officer could sign off on such a directive or establish a network of doctors who could provide this critically needed directive. Additionally, the issue of the alarming number of overdoses highlights the need for safe consumption sites across the GTA and throughout the province. We know consumption sites are a necessary component of effective service provisions for individuals who use substances. Lastly, we are aware that many agencies struggle with providing best practice standards when working with folks who are active in their drug use. Folks who are on the nod are sometimes asked to leave agencies and drop-ins and often have nowhere else to go. So public health may be in a good position to provide best practice training to agencies across the city, as they have done a lot of work in this area. And then I have a bit of time, so I just wanted to comment on the Good Samaritan law. And Mr. Burnside, you were asking about if people not wanting to call 911 during an overdose, if that was reality or if that was perception. So based on my experience out in the community and working in drop-ins, when people are in an overdose situation, they won't call 911. A lot of the times people have, or some of the times people have outstanding warrants. So if you call 911 and there's either drug presence, drug paraphernalia, or somebody with an outstanding warrant, they will be arrested. Or if the police do show up, they'll ask you, do you want to go to jail or the hospital? And the people will just take off. So that's been our experience, which is unfortunate. Anytime you mention that you've called the cops, people will just match once they wake up. So thank you.
Okay, thank you for your presentation. Questions from the board? Okay, thank you very much. We appreciate your comments. Last but not least, Susan. Great to see you. You have 10 minutes.
Good morning. I'll just take my 10 minutes. So my name's Susan Gapka. That was something to watch, the 25-year works presentation. Good agenda setting. Brings us back down memory lane. I want to dedicate just what we're doing here today to a woman named Carol Pollock, who passed away of cancer about almost 2 years ago. I worked with Carol at Parkdale Community Health Center when we set up the setting up the street outreach program at Parkdale Community Health Center, along with Walter Cavallari. And I just, it's actually a little emotional, but I first heard about naloxone when I was living on the street, sleeping on railroad tracks. They've got them all boarded up down there in Parkdale now. There's a wealth of redevelopment down in the neighborhood. But we talked and talked and talked. And then we invited other people from the streets to come in, where a satellite needle exchange program, a street outreach program developed out of that. We created the Finally Understanding Narcotics group, and which actually I think has been longest running support group of that type in Canada, I believe, up until recently. But so it was a big memory there. But what harm reduction does, in essence, is you have a barrier. And so what you have is illicit and illegal drugs, you have a stigma, and what you do is you have a health center and healthcare providers on the other side of that. And what harm reduction does is essentially tears down that wall so that the two can interact. And so that's why I want to support the recommendations in this report. Shortly after that video was made, there was a series of there was stronger than usual heroin on the streets. And I'd say probably six or seven out of every 10 injection drug user in Parkdale and in Toronto and around passed away, died of a drug overdose. Much like the AIDS epidemic would be related to, they were dying every day. And so let's not go back that way. So I'm looking at my time here. So I have some other remarks here. But then what happened, some of you might know my story. I got off the streets through assistance from the Parkdale Community Health Center in 1997. So it's been 18 kind of wonderful and exciting years. I sat on the board of Breakaway Services on the board of Parkdale Community Health Center. Even had the opportunity to return there last year as we celebrated. I was a guest speaker, the 30th anniversary of the health center, where El Mirinda, the original ED, and Akash Maharaj came back and spoke as he was chair of the board. So those things are kind of possible in the world we want to create by moving forward with harm reduction strategies. I think I've got kind of the general idea of where I'm going on this, but just to address some of the specifics here. Around this, it was somewhat, I'm going to go through this list here. Naloxone, health promotion and education, Good Samaritan, supervised injection sites. How about consumption sites as well in Toronto? Long overdue. Opiate substitution. What people need is not more enforcement, trading in of fentanyl patches, in my view, and I'm willing to discuss this more, but I think what we need is treatment on demand. What we need, or what we need, what people need, what the city needs is pre and post housing for people going into treatment. What we need is supports. What we need is to address the social determinants of health. An enhanced poverty reduction strategy, and perhaps embedding harm reduction into that poverty reduction strategy. And by golly, I've covered it mostly in 10 minutes. But here, I got a letter in the mail last night. Let me read it. Let me read the first paragraph if you give me an extra minute there. Dear Susan, this is from George Brown College. It is with great pride that I congratulate you on your nomination to the 2015 Premier's Award. Oh, Premier, let me start that again. It is with great pride that I congratulate you on your nomination for the 2015 Premier's Award in the Community Services category. A nomination for this prestigious award is an honor, and as an alumnus of George Brown College, we are proud of your career achievements and your service to your community. I'd close on those remarks and hope that you'll adopt the recommendations in front of you so that we can enable people to stay alive long enough to have the opportunities that other Toronto residents otherwise may not have or otherwise already have. Sorry.
Okay, thank you very much, Susan, for your comments. Are there any questions? Okay, thank you, Susan, once again. Okay, so we've heard the deputations for 6.4 and 6.5, but we'll focus questions for 6. Well, I guess you can question the medical officer of health on both items now, but we'll vote on them, of course, separately. Are there any questions of staff? John? Doctor, I gave you a doctorate. Councillor Burnside.
It's a little bit of a stretch, yeah.
Yeah.
I do have a couple questions. One, I'll come back to the Good Samaritan issue, legislation, but it says rescheduling naloxone to allow provision without a prescription. Okay, so one of the speakers mentioned that you can't just hand it to somebody because there's a danger of a re-overdose, if you will. So what if you don't have a prescription where there's presumably some level of education? How do you ensure that level of education?
Well, I think this is a federal regulatory decision, which drugs are prescription and which are not. It's based partly on risk, but there are some non-prescription drugs that carry risks with them. And there's provisions in terms of what kind of labeling requirements there are, what kind of information, basic information the individual who's making the decision to use the product or not needs to have. So I don't think that requiring a certain level of knowledge is necessarily the dividing line between prescription and non-prescription. What we're finding is that the kind of people who really ought to have access to naloxone, who are likely to be there in time when the overdose occurs, includes people who wouldn't need it for themselves. Right? So the person for whom it could be prescribed because they are an opiate user, may be unconscious on the floor, not able to tell the person where my kit is. Right? So you want the family member or the friend or the neighbor to have the kit. And right now, under the federal regulations, it's not possible to prescribe to that individual. They don't meet the indications. So broadening access in that way by changing the federal regulation would be very helpful in putting naloxone into the hands of the people who could actually use it.
Okay, thank you. And there's no danger of people having that kit? Like, of administering too much or anything like that?
No. In fact, there are situations in an emergency room where someone will come in unconscious and will be given naloxone without really knowing whether or not they've had an opioid overdose, because if they haven't had an opioid overdose, it doesn't do any harm. If they have had one, it's life-saving.
Okay, and then, thank you, that's helpful. And then my last question comes down to the Good Samaritan legislation. Now, so there are two issues as I see them that have been brought up. One is just sort of the criminalization of users and arresting people that are users that have paraphernalia, drugs, whatever on hand, which I'm against. But then there's this, one of the speakers brought up the issue of outstanding warrants. Mm-hmm. And that to me is related but also different. So this Good Samaritan legislation, does it talk to the warrant issue as well?
I'm not aware that it does. I'm just wondering whether Susan Shepherd could shed any light on that aspect.
Yeah, so as I understand it, there are a number of states, in particular the United States, that have Good Samaritan legislation, and some of them do address this issue. So they're not necessarily a broad shield that I'm not sure of the exact details of which may be dependent on the criminal charge, but the shield is often meant for possession of illicit substances, rather than a warrant for another more serious crime. So they're not blanket shields of protection in most of these states, but they do shield against more minor offenses such as drug possession.
And that makes sense to me, and so thank you for that information, but I guess my question still is, what's the intent of what we have before us? Is it the same as what you're saying in those American states?
Well, the details in the prescription for life in terms of creating Good Samaritan legislation don't go into that level of detail. I think that if the federal government was open to having a conversation about changing the Controlled Drugs and Substances Act to allow for Good Samaritan legislation, that all of those pieces would have to be thought through in terms of what it would look like here in Canada.
So we just want to open that discussion?
Sure. Yeah.
Okay, thank you.
Thank you. Other questions, staff? Councillor Cressy?
Thanks. Well, it was mentioned to the medical officer of health by a number of the deputants that they've seen an increase in the number of deaths due to overdose. Is that the research that we have in front of us as well? Do the numbers back up what we're seeing anecdotally out there?
Yes, that's right. The data that's in the report that's before you is not anecdotal. It is a review of the death data that we get from the Ontario coroner, and it does substantiate an increase in accidental drug overdose deaths, with the most important part of that increase really associated with opiate overdose.
And do we know that that substantial increase is associated with opiate overdose? Is that heroin? Is that fentanyl? Do we know what the majority or the significant driver is of that opiate overdose?
Well, there is we have fairly detailed data on which drugs have been found in the overdoses. Often there's more than one drug, and there's some issues around how do you decide what the contribution of each of the drugs is. But certainly opiates as a class, I think there's one graph that we put in this public report, as a class seem to be experiencing the greatest increase. Part of that is fentanyl, but not only fentanyl.
And I read it correctly that we've seen a 41% increase in overdose deaths from over a 10-year period, 03 to 13?
Yes, that's correct. If you compare the number of deaths from 10 years ago to the most recent available year, it is a 41% increase.
And just, I want to come to some of the recommendations, the specific recommendations in this. So, building on what Councillor Burnside touched on there, so the request to look at Good Samaritan legislation, this is to initiate the conversation with the federal government, perhaps a new one, perhaps the same one we shall see in 4 weeks. But this is to initiate a conversation with the feds to roll out the full details of what that be, understanding there are principles around hot pursuit, for example, and others, but would be part of the conversation.
Yes, certainly the recommendations, some of the recommendations in the Prescription for Life document don't go into that level of detail, exactly what the policy would look like. Broadly speaking, they are recommendations which all share a common goal of trying to increase access to overdose prevention methods.
And is it your view that we've heard a lot of discussion about naloxone, that increasing access to naloxone with the appropriate training, but increasing access to naloxone would save lives?
I think there's every reason to believe that that's the case.
And does our report and recommendations, do we address stigma? It was mentioned that overdose causes death, but I think it's fair to say that stigma also causes death as well. Do we address stigma?
We certainly address it regularly in our reports, in our work with the community. It's not a major focus of this report, which is really focused on overdose.
Thank you.
Thank you. Other questions? I have just one. People asked other ones. I noticed in the Appendix A, there's no mention of, or maybe I didn't see it, and maybe it just needs to be pointed out, is EMS and fire. Very often, fire is the, if someone does call 911, sometimes fire, because we have 100 fire stations across the city, they are the first ones present. So is that just... I'm sure the intent is there, but I don't see any language to that.
Okay. Well, EMS, of course, does use naloxone, and there's some data in the report about the frequency with which they've been using naloxone. We work closely with EMS when we develop the POINT program as well, because we want people to call 911 and for EMS to be on the picture, on the scene as quickly as possible.
They're covered then.
They're covered. Now, fire, I'm just going to ask about.
No, currently, fire and police do not carry naloxone, as far as we know.
And the intent here, even though they're not mentioned fire here, is to suggest to, I guess is it the federal government, that they be permitted to carry them as they attend to emergencies? Like, they have defibrillators, and they're well-trained in that, and...
Yeah, I think there are issues around fire carrying prescription medication and administering it as well that need to be looked into.
But in principle, there's no reason why fire professionals who are responding to medical calls a lot of the time should have access to the same means to intervene in an overdose as the police, who may also be, again, on scene at the time.
Right, especially if it's if this is something that can be EpiPenned or through an intranasal device.
Yes.
Okay, so I'll leave that to your good judgment. Are there any speakers to this? Let's start with 6.4. Councillor Cressy?
Let me start off, first of all, by thanking everybody who deputed, both to the individuals for your experience and the courage to share it, but also to our staff. Before we had this, we saw the presentation of the works, and we saw some of the frontline staff who are there and living day in and day out doing exceptional work. And I want to recognize both the individuals and the staff who've deputed and done being on the front lines. What's clear in this report, and we've heard it from deputants, we've read it in the report, there are too many deaths in our city because of overdose. That's the bottom line. There are also too many deaths in our city due to stigma associated with using. They go hand in hand. And the reality is these deaths are preventable. We can save lives. And that's what this report is seeking to address, is measures that we can take today to save lives. We've seen people, Dennis, one of the deputants, talked about a crisis and seeing it. And we've seen a 41% increase in deaths due to overdose over a 10-year period. It's on the rise. We also heard that it's now the second leading cause of death among young people. This should raise the alarm bells. And we have, as a city, we've done a fair amount. We have a Toronto drug strategy that looks at harm reduction, treatment, prevention, and enforcement. We have an active sector of agencies on the ground doing exceptional work. We heard from the works about the POINT program, but there's more we can do. And I think when you look at this report, it talks about naloxone. We know it saves lives. We know that if people had access to naloxone, it can save lives. We've used it as part of the POINT program. More than 2,000 kits have been distributed. It's been used more than 300 times. We heard the medical officer of health speak on. And we know it saves lives. So let's make it more available. And that's what we're asking here, is on-site access, whether it's in hospitals or correctional facilities and others, to broaden the list who can prescribe naloxone. Frankly, I think it should be easier than that. But this report speaks to more than just naloxone. It talks about a comprehensive plan that we need to develop in this province, in this country, to deal with overdose, including reducing stigma. And it talks about looking at Good Samaritan legislation. And I think at the federal level, that's an important point to look at and initiate the conversation on. And that's around reducing the barriers as someone calls 911. There's a lot more we can do. That we know. These recommendations touch the surface. Unfortunately, because so many of them are outside of the jurisdiction of our municipality, they don't allow us to do the work that needs to get done, but rather to advocate for what should be done. And that's the least we can do. And I think we should do more. So I'm happy to support these recommendations.
And I'm assuming you're moving them as well? You're moving them? Okay, any other further speakers? Okay, sorry, Elisa.
Oh, yeah. Thanks. Again, thanks for the report and to the speakers as well. I wanted to just make an amendment to number 4 because of the specific recommendation in the Appendix A towards First Nations, Inuit, and Métis. Perhaps we can specifically send it to the First Nations Inuit Health Branch of Health Canada Non-Insured Health Benefits Program, if that could be done.
You'll have to give the specific wording to the clerk. Great, I'm sure that's friendly. Anything else? No. Okay. Okay. So we'll just. I just want to say one thing additionally. You know, Toronto has a wonderful Toronto drug prevention strategy. It's headed by Susan Shepherd, who works cross-departmentally, cross-sectorally. It's a wonderful, wonderful collection of people that have carried the ball, boy, since it's got to be 15 years, 2005, 10 years? 10 years. And they do great work. And so I think, Susan, kudos to you, kudos to the drug prevention strategy, and Councillor Cressy for this report and the next report. I think that's that committee, that group of folks that assemble and meet regularly have really been in the forefront of us as a city thinking through drug prevention in Toronto. Okay, so we're ready to vote. Any, no more speakers? Going once, going twice. Okay, all in favor as amended. I'm sure that's a friendly amendment. As amended, all in favor. Opposed, if any, that's carried. 6.5, Councillor Cressy. Want to move that as well? Okay. Usually, just for the sake of everybody, if you forward a report, usually we ask the staff to report. So, Dr. McEwen, you've reviewed this, and your staff have reviewed it, and you're good with these motions. Great. Okay. Any debate or discussion on that? All in favor? Opposed, if any? That's carried as well. Okay, we're on to the next item. We have two more items to go, 6.6, 6.7. I notice we have 45 minutes. So if you do the math, we have 13 deputants on the poverty reduction strategy, 5 minutes apiece. I have a feeling we're going to the we're going to be meeting after lunch. So just in terms of you thinking it.
Mr. Chairman, I can't come back after lunch, and so unless we want to move that the deputants speak less than 5 minutes and we can hear all of them and complete the agenda, or I like to deal with my item before lunch.
I won't be here after lunch either.
You can't either? Oh, okay, ouch, 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 okay. So, Councillor Annunziata, regrettably, folks, because we're going to lose quorum after lunch, we're going to go to 3 minutes per deputant. So I'm going to ask you to keep your comments tight so that we can basically finish the agenda. Okay, so moved by Councillor Annunziata that we change the procedure to allow for 3-minute deputants, and we'll do it with some efficiency. Okay, all in favor of that motion? Opposed, if any? That's carried. Okay, 3 minutes. First, Rachel Gray, Chair of Toronto Food Policy Council, followed by Leonid Makaruchko, the stop, and Russell Woods to start. Welcome, Rachel. Press the button in front of you. Yeah.
In support of the poverty reduction strategy and TO prosperity, very glad Councillor McConnell is here, our champion on this. This is a significant moment for the City of Toronto, both because it's our first poverty reduction strategy and because of the collaborative process that went into and that involved so many different members of the community in the drafting of this strategy. Many of you know that the Stop Community Food Centre has been involved for decades working at the grassroots. Our roots are in Kensington Market in the 1970s. It is built on that commitment to working with community, building community access to healthy food in a dignified way that brought us to working on the poverty reduction strategy, and in particular to working with the Commitment to Community group that came together months ago last year to work on the entire strategy. Our focus obviously was somewhat more focused on food, but we attended meetings throughout the course of the year. Our staff did, as did community members, the Commitment to Community process. We were involved in developing the recommendations, identifying priorities for the work, and delighted to do so. This morning I'm wearing both hats, both the STOP and TFPC, speaking on recommendations. And assuming that the Board of Health is a strong ally, an ally in the work to have the City of Toronto understand the role of food, the critical role of food, and a sustainable food system in our individual and community health, as well as the economic and environmental health of our city. I'm going to speak to just a couple of specific policy areas. start by acknowledging the leadership of the board and the city on the student nutrition file. Urge continued efforts on this particular program, expanding the program, consideration of a full universal program, and including in that secondary students and designated neighborhood improvement areas. Also specifically calling on support to and advocacy with the federal government on a universal student nutrition program. I was delighted to hear the Green Space report. The Urban Agriculture Committee of the cities has done a lot of great work breaking down the silos between different government departments or city departments, but this committee's work needs to move much more quickly, we would hope, removing barriers such as zoning, licensing, and planning, which will increase urban agriculture, the food production in public and private spaces. Very exciting work is happening in the hydro corridors, planting gardens, and this should be something that is celebrated, encouraged, and expanded to also include other public spaces, parks, schools, the discussion we heard, Toronto community housing buildings. Councillor Doucette spoke to the importance of community gardens. We, of course, would echo that. To say nothing of the fact that these market gardens would also provide additional income for many different communities. I want to speak very quickly to procurement, to using the purchasing power that the city has. Money that is going to be spent anyway should be spent reflecting our goals and our values. So, for example, the Food Reach program that is currently an emerging effort should be supported by the Board of Health and in a way that would support local food efforts and getting healthier food into community organizations. Finally, on this is just adequate income. People in Toronto who are food insecure, people in Toronto need to have better income, be it in the recommendations in the poverty reduction strategy that the city take on the role of a living wage employer, the advocacy that's required around social assistance rates for everybody in this province. We need bold income leadership on income so that Toronto can actually be a livable city for all of our residents.
Thank you, Rachel. Sorry, I don't mean to be rude, but I'm going to be in trouble with others. Any questions? Councillor McConnell.
One very quick question to all of the deputants. If you could please have your notes either today or sent to the secretary, to the clerk, it would be very helpful for staff. That's all. That's the only question. Do you have that?
Will you send your notes to staff?
We will.
Yes, okay, thank you. Okay, thank you.
Okay.
Any questions by board members? Seeing none, next deputant is Leonid Makaruchko. Hi, greetings.
Hello, Chair Mahavik and ladies and gentlemen. My name is Leonid Makaruchko. I have participated in the STOP Community Food Program for almost 2 years. I'm also a member of Bread and Bricks Group, Food and Shelter, people who have devoted themselves for social justice. I have a mission today to represent Bread and Bricks, to advocate for a good strategy to fight hunger. All we know that food is one of the basic human needs and an important determinant of health. But I see in our neighborhood, Davenport and Symington area, that people experience food insecurity. With some financial assistance from welfare or DSP or pension, people are not able to acquire food in socially acceptable ways. Prices in stores are skyrocketing. That is why they come to the STOP Food Center to have breakfast and lunch. The STOP Community Food Center also runs a food bank program supplying mostly fruits and vegetables and dairy products. It is wonderful that most of the produce is grown on the farmland of the STOP. I'm not sure if they are certified, but the taste is great. Also, it is important that people volunteer a lot for the STOP Community Food Center. It is a life experience with a positive emotional outcome. Ladies and gentlemen, is not that amazing program? Is not that a good strategy to fight hunger? Almost more than 300 people are served every day, Monday to Friday. It is obvious that we need more investment in the STOP or like the STOP community food centers, creating a number of them in Toronto, in addition to increasing minimum wages and social assistance and ODSP rates. That is a great way to fight hunger. I want all of you to welcome to the STOP Community Food Center to see our facilities, our people, and share our food. Welcome.
Thank you, Leonid, and thank you for keeping it to 3 minutes. Seeing no questions, Russell Woods, followed by Kabindra Sharma, and then Linda Johnson. Welcome, Russell.
Thank you,
Nice to see
Mr.
you.
Chairman and members of committee. I'm here today to talk about the need for community gardens. We have them. We need to expand the project. And in fact, I see some familiar faces around here who have heard me bang my drum on this subject before. But I'm a member of, a volunteer of East Scarborough Storefront, East Scarborough Boys and Girls Club, and the local food bank, and I have gardens in all of their backyards. I'm a resident of Ward 44, and I'm most active in Ward 43. Wrong card. Anyway, let's see what else I've got. What we do is we provide healthy, organic in many cases, but certainly pesticide-free food to people who are at a disadvantage. This is premium stuff. And I think the medical officer of health will agree on the nutritional value of such food. It's local, it's clean, and it's certainly nourishing. We do it on a volunteer basis using whatever resources that we can be afforded, and we rely a great deal on government to agencies to give us space, to give us some facility to do our work. We need more space for this cause, and that's what I want to sensitize councillors to. There's a great amount of municipal space, hydro space, parts of schoolyards, and bearing in mind that food security is such an important part of poverty need and reduction that I cannot see that this is anything but a motherhood issue, but we do face the need for more resources. There are discretionary resources, there are budgetary resources, and most certainly if you can be sensitive to the fact that we need those things, let us go forward and do our best for those in need and our own health too. It's green space. Thank you very much.
Thank you very much, Russell. We appreciate your comments. Kabindra Sharma. Kabindra Sharma. Going once, going twice. Okay. Linda Johnson and Dorothy Amego from Women's Habitat of Etobicoke. Are you here? Welcome.
Good morning, ladies, councillors, ladies and gentlemen. My name is Linda Johnson. I'm from Ward 7, and I'm with the Women's Habitat. Today, I'm here to talk about food security and access to good and healthy food. I would like to speak, I would like to speak about the issue of food security for low-income families, low-income individuals, young single parents, and seniors living on pensions who find it difficult to afford healthy food choices and thus maintain a healthy diet to achieve optimum health. The purpose of my speech today is to seek help from counselors to provide food security by increasing access to healthy student food programs such as breakfast programs, lunch programs, and snack programs. Also improve the quality of foods at the food banks and provide more healthy meals on wheels for seniors. The importance to our community and changes I would like to see happen are providing food security and access to community health centers such as LAMP, Queen West Community Center, Flemington Community Health Center, Delty Health, and eye care will also help a lot of families struggling to raise young children in our communities improve the quality of their overall sense of well-being. A person with diabetes, for example, cannot get all the special nutritional needs if the local food bank is their only source of meals. It's their only source of means of food supply. There should be more access to services in communities that persons struggling with lower income can access to improve the quality of their lives. Thank you. Yeah, that's it.
Thank you very much for your comments. Are there any questions? Thank you very much, Linda. We appreciate you coming. Is Dorothy here? Dorothy Amigo? Dorothy. Thank you, Dorothy, for coming.
Thank you, too. Good morning, everyone. Thank you for having me here. I'm Dorothy Amego from Etobicoke Ward 6, and I work for APACH, Afro-Panam Center for Cross-Cultural Competency Coaching, and I work as a public policy issues advocate for Women's Habitat. And
right into the mic.
I've worked with Daily Bread intake work for over 3 years now. I'm here mostly to talk about preventative health care because based on my work with Daily Bread, we look after 700 clients in a week and about 700,000 a year. So we get to listen to each and everyone's story, most of which are very touching. The main challenge we have, of course, is the funding cutbacks that has resulted in training of basic training of the clients. We give them foods that they know nothing about. Most of them are new. And we do our best to train them, but it's limited without that support. And we serve through 142 member agencies, most of whom do not have cold storage, so we are supplying grains rather than fresh foods and vegetables. So there's limit there. Because of this, we have a lot of nutritional deficiency disorders, clients with that, and we end up sending them to naturopath doctors and other doctors as well. But the naturopaths have really been very helpful to us in that they can identify where the supplement needs are and tell us diabetics, give them this, people with celiacs, give them that, children, give them that. So they are helping us on a voluntary basis. I, for example, attend a naturopath clinic once every month, and they're very useful and helpful. But they have limitations because they have to do everything through the conventional doctors. Sometimes, to find out if your iron level is enough, they have to wait. So they have a lot of limitations. And the naturopath doctors have requested us, community advocates, to advocate for them to have equal financial recognition as well with the conventional doctors, given the fact that they're working together at this point in time, and they're working very, very effectively. One of the things that the naturopath doctors would like to do is increase training, especially for the youth. The youth, especially in our Etobicoke area, most of them are now addicted, so addicted that they have to be educated on how to cope with this. We've been able to send them to places like Alcoholics Anonymous and so on to be able to cope with their addictions and possibly come out of it. So we are encouraging the youth to have a healthy lifestyle, and as well, when we give food to them for access, we have to make sure that the food is easy to open, because otherwise they'll be hungry all the same. So there's always a balance there. Should we give the easily openable food to children or to the addicts? You know, the youth are smoking cigarettes with carbon monoxide, you know, alcohol, drugs. They really need to be taken care of, otherwise we are in trouble. Apart from the youth, we have the disabled, people who cannot access our services. So we are also advocating for that, more support so that our volunteer on wheels can be able to approach our members in the community who cannot access food at the Daily Bread Food Bank. So I'm hoping that the recommendations that we have submitted and that we are submitting will be looked at very closely by your team and given very favorable consideration in this regard, because a healthy society is a wealthy society. Thank you.
Thank you very much, Dorothy, for your comments. Susan Gapta? Susan, 3 minutes. Be tight.
Oh, someone's left their glasses here, so I'll just put them aside. Hi. Yeah, so I'm supporting the work. I spoke as an individual earlier. I just wanted to clarify that. Today, at this point in time, I'd like to speak as founder and chair of the Trans Lobby Group. And talking about trans issues and poverty reduction seems important when I woke up this morning, besides overdose prevention. But trans people's lives, transsexual and transgender people, and the umbrella, our lives are mostly centralized in some ways, especially a particular segment of the population like myself, around access to health care and significant rates of poverty, lack of education, which I'm thrilled that the city is moving forward with a consultation on Friday to start to address that gap. But I just wanted to sort of talk about that. And the poverty thing, like I said previously in a way, I hadn't addressed. But you know, poverty impacts people differently than those who are not living in poverty or in low-income situations. And so there's addressing the social determinants of health, and especially social determinant of health and housing, is critical as we move forward. So I just wanted to say that as we move forward, so that you can move forward to the next stage of the poverty reduction strategy. Just access to health care. And so I'm attending, I didn't know it was next week, October 1st. There's in Halifax, Canadian Professional Association for Transgender Health. I'd like to bring news to them that Toronto's Board of Health is fully supporting moving forward on addressing some of our gaps. And I'm at 2 minutes. Give me another 30 seconds. But one thing I wanted to address, I ran in the Civic Run last Tuesday. Oh my goodness. I ran much better at the Terry Fox Run 10K. And I had a much better day. But that aside, I was asked to register in 2 categories, male or female. I just wanted to put that out there as perhaps a way of thinking, moving forward. I deputed more than 10. I think, Joe Mahavik, you were, we had what was it? It used to be a round table on human rights and equity. And I had asked that, to apply for the Board of Health or any of the agencies, committees, ABCs. I don't know if it's changed. Thank you. I don't know if it's changed, but last time I looked, there were 2 options, male and female. Let's take a look at that.
Great. Thank you very much. Next is Alejandra Ruiz Vargas. Alejandra, welcome. And then Adina Lebo and Agnes Thompson. Welcome, Alejandra.
Thank you. Hi, everybody. I would like to thank you for the opportunity, because it's a huge opportunity to speak today for me here with you and to tell you why I'm here. I'm here because I see a need of a mental health worker at the triage of the ER in the hospitals of the city of Toronto. I am a follow-up support worker for the city, and my job had opened my eyes to many positive things and to ones not so positive, but at the end, knowledge is power. One of my roles at my job is to accompany my clients to hospitals when they are sick. So these visits, and believe me, have been numerous, allow me to encounter a disconnection between the social component of the individuals and the healthcare. If we want to provide care to a person, we cannot dismantle it, the person. We need to look the person from a holistic view. This is the reason why I'm convinced of the need for a mental health worker or a concurrent disorders one at the triage of the hospitals in the city of Toronto. I accompany a client for about 1 year and a half to the ER, sometimes 3 times a month, sometimes 2 times a week. In this lapse of time, he suffered 3 heart attacks. His cirrhosis became chronic, and he fell so many times that I stopped to count at fall number 10. When he fell, he of course did many damage to his body. And the medical team explained him that he can die if he doesn't accept the treatment. But he simply walked away all the times and refused the treatment. In one occasion, he disconnected himself from the IV and walked away with a needle attached to his arm. The medical team didn't have the authority to go against my client's will. Even though this writer, me, plead them to phone him or to found a PGT. Unfortunately, my client died 3 days ago. I'm here to propose this committee the need of a mental health worker or concurrent disorders in the healthcare systems. And I know this committee goal is to look for strategies to reduce poverty in the city, and the idea to have expertise and trained workers that can fit and assess the needs for people who have mental health issues or addictions or both combined, that is called concurrent disorders, will reduce the cost of operations of the hospitals, will prevent a long wait periods and the hazard of responsibilities that doctors had when they need to decide for someone who chooses not to be treated because their mental health or their addictions. This is a little, okay, it's finished?
Sí.
Oh, I'm sorry, thank you, gracias.
No problem. If you have one sentence, can you say one sentence that's going to knock our socks off? La última.
I think so, guys. We need to change the legislation in order that a doctor or practitioner health cannot be sued if he saves a life.
Okay, gracias, thank you.
De nada.
Any questions? Okay. Next is Adina Lebo, followed by Agnes Thompson.
Hi there, everybody. Thank you. I'm here on behalf of a coalition of seniors organizations. This includes Canadian Pensioners Concerned, Care Watch, CARP Toronto, the Toronto Council on Aging, and the Toronto Seniors Forum, which is part of this august structure. Innovation is often defined as combining existing ideas in a new way. So the idea is really to look around and see what we're doing now in terms of legislation and infrastructure and reassemble it for the future. As tempting as it may be to stick with what we're doing, the comfort of doing what we've always done and the tendency to retrench, to weather the storm of seniors passing through the system, the old approaches will not work in the new economic reality of no money and the size of the aging demographic. The inconvenient truth is the storm of seniors won't go away. In addition, the medical technologies are keeping them alive longer. 680,000 Torontonians are over the age of 65 now, and the figure will double to 1.2 million over the next 10 to 15 years. Many middle class and upper middle class will be facing poverty simply because they haven't saved enough. Retirement can last 30 years or more now because of the advances in medical technology, and the fastest growing demographic is 85 plus. When it comes to health services, we just have to keep older people healthier longer. Proactive behavior is necessary, and we have to keep people out of the hospitals where the cost is high and at home where the costs are lower. Healthier food, healthier lifestyles, access to support services. Seniors use up a large portion of the budget, and we have to lower that proportion. The network agrees and supports the poverty reduction strategy recommendation and would like to add expanding the fleet of mobile dental trucks going to seniors' residences and other long-term care homes. There's a 2-year wait right now, but research is showing that a diseased mouth foreshadows disease in other parts of the body. Our medical system is currently based on crisis care to get to the hospital. It has to be refocused to chronic care for the large demographic that's coming through. Keep people at home. It's much less expensive. A hospital stay is $1,000 a day. Staying at home is $50 a day. And with the number of seniors coming through the system, we have to keep them healthy and at home. Healthy and at home should be the new mantra for the 21st century. Thank you.
Thank you very much, Adina. Helpful comments. Any questions? Seeing none, we'll go to Agnes Thompson, followed by Robert Asawek, Leona Lowe, and Sean Mahar. Welcome, Agnes.
Good afternoon. I am a little bit nervous. It's my first time being here in this room, and I'm very honored to be in your presence. Seeing your pleasant face make me feel a little more comfortable. My name is Agnes Thompson. I am a resident of Ward 43 in Scarborough. Today, I am here to show my support for a strong poverty reduction strategy for Toronto. I want to advocate for free dental care for low-income working adults and seniors. In the city, I see many people in my neighborhood who can't afford to pay for dental check out of their pocket. Many of those people work 2 and 3 jobs to support their family and try to make ends meet. These people suffer in silence while working very hard to provide for their family. I heard that Toronto Board of Health supports goods program so I am urging you to consider providing basic dental care for adults and from low-income family. I understand children get free dental care through the city, but adults who are working poor and they do not qualify for free dental care. Free basic dental care and for low-income adults who will allow people to save some money and get the help they need. Hardworking adults in the city deserve it. I request you to incorporate this in the poverty reduction plan to give some people financial relief and quality dental care, because we care for people in the city and we need to be there for others who are less fortunate. Thank you for the opportunity.
Your comments, Agnes.
Be in your presence.
Likewise, thank you. Next is Robert Asuek, I hope I said that right, followed by Leona Lowe, Sean Mahar, B. Lee, and then Kabindra Sharma. If you could really be tight, that would be so appreciated. Thank you.
Good afternoon.
Afternoon.
My name is Leona, and I am Ward 27.
Hello, my name is Bobby Robert Assink from Ward 30. We are members of Friends Against Poverty, a group based at Yonge Street Mission that is working to make life better in the downtown east sector.
It's a great city to work on poverty reducer strategy, because if we put all our pieces together, it makes us stronger for people to see what they need and what the most important issues are to address. The more money you have, the better food you can buy. So if ODSP or OW rates are increased, we can all eat better and have better health. If you go to a food bank and you can see what many people have to eat, it's not much. We need to educate people so they know there are many people who can eat a healthier diet, and have more community support for people is also a way of reducing poverty. Educating people to help understand well-being, more community gardens, help agencies to bring people together so that we can talk to each other. So recommendations number 6, that seems how all these things fit together, is one we think is very important. We agreed that accommodation 6.6 to increase dental coverage, to everyone living on low income. We know people who have waited a long time with pain before they go see a dentist, and sometimes it takes 2 hours for a dentist to get the tooth out because they wait so long. When we go to the emergency room, every time there are been very long waits. We would like to see the Board of Health to speak to the provincial level of government to work for a shorter waiting time. Thank you.
Thank you very much. Any questions? Thank you, and thank you for speaking together. We appreciate your comments. Next is Sean Mahar, followed.
Sorry, it's still me. I was waiting for her to finish.
Okay. You're a gentleman.
Across the actual thing. So for us, more support for people with mental health issues is very important to make lives better. We think that the city should do more training of staff, including police officers, so that they are more understanding and caring, have more respect for people with mental health issues. This should be include care for staff that do this work, because it's hard work. That is found in recommendation 21. For the police, there should be a mental health professional that accompanies police to every call that relates to mental health. and we are calling for the city to find ways to hire more people with mental health concerns, including as peer workers. Not only this, but the city can encourage private companies to do more hiring and give people support so they can succeed in the workplace. Also, there is a lot of seniors who pay far too much for their medications. The city should work with other levels of government to ensure that there is coverage for seniors so they don't have to be forced into making impossible choices between buying a prescription and buying food. We see a lot of ways that health is connected to reducing poverty, and think that the city can do a lot to make life better for everyone by working to put in the recommendations in the report. We want a very strong plan with funding and career goals.
Great, thank you. Thank you very much, and we appreciate your comments, and of course, you're going to forward them to the clerk. Okay. Thank you. Sean Mahar. Welcome, Sean. 3 minutes. Keep it tight. Thank you. We're going to lose our audience. We're going to lose our board.
Executive Director of Social Planning Toronto. And I don't want to come and call on the Board of Health to spend money in ways that are generous or to dole out resources in ways that are kind or sympathetic or progressive. I want to encourage you to invest in ways that are smart. Poverty is expensive. I won't spend a lot of time talking about the big impact poverty has on any effort to address the health of people in the city, or the incredible impact it has on lowering the cost of caring for those folks. We have research that shows that reducing poverty lowers hospitalization rates by 9%, saving Canadians an estimated $8.5 billion. Estimates for Ontario alone show that poverty costs the economy about $30 billion a year. That's why hundreds of doctors have been calling on the province's health minister to bring in a guaranteed annual income, because the right prescription for Ontario is to address poverty. But the people around this table, I think, already know that. The case for poverty reduction from a health perspective is already too strong to ignore. So I want to focus on the process of poverty reduction, because knowing where we want to get to is not necessarily the same as knowing how to get there well. One of the things we know from looking at efforts around the world to address poverty reduction is that poverty reduction strategies need to learn and change. That we will, because poverty is complex, get a lot of things wrong in the early going. We'll need to reevaluate and reorient and reconsider as we go. We need to have a strategy that is a living document, that is a journey, not just a destination. And to do that, there's a couple of other things we need to do. We need to be transparent and include the public so we get the feedback we need to know how we're doing. We need to have goals that are clear and measures that are clear so we know how we are doing. We need to focus on the evidence, on what the facts tell us, but that has to include the evidence from people with lived experience. You've heard a great deal today from people who have experienced poverty firsthand, and they can tell us things that we don't learn from books and we don't learn from statistics. And we can't do it alone. We're going to need to collaborate a lot and coordinate a lot to bring our community partners and our communities into the process of not only planning and reviewing, but implementing a poverty reduction strategy. The last thing I'll mention is simply that the process matters a lot, but the outcome also matters, and to achieve it, there are 3 things we need to commit to as we move forward. 3 things we're hoping Council will commit to when it considers the poverty reduction strategy, and that this board will convey to Council. And one is that we do have to invest, that poverty is a challenging problem. It won't be solved easily or quickly. We don't expect the 2016 budget will end poverty forever in Toronto, but if there isn't a meaningful down payment, then engaging people in the real work of poverty reduction is going to be impossible to do, because they won't believe that Council is genuinely committed to achieving that goal. We need to empower staff to go and do the things that are free. There's lots of things we can do that don't cost money, and our staff can start that tomorrow. And they need to begin to plan for the more complicated things in the future. So investing early, empowering staff, and planning ahead will help lead us to a good poverty reduction strategy. Thank you.
Thank you, Sean. Seeing no questions, we'll move on to B. Lee. Any seats fine?
Morning. Good afternoon, everyone.
Have a seat. Are you B?
I for 5 minutes. When I up to my 3 minutes, I know. Right up to my 3 minutes, can you remind me so I can finish
Oh, I'll remind you, don't worry about that.
my ending paragraph? Thank you. My name is Billy from Scarborough North. I'm here to tell you my story, how the homelessness and joblessness had affected my health, my well-being. On a very cold and windy Thanksgiving Day, I was homeless with a full-time job. Because of the high cost of rent, I was seeking shelter in a TTC subway station at night, as I had no place to go to get myself out of the cold. Other time, I stayed 4 nights at a 24-hour Tim Horton. Because I'm a lady, I worry about my safety, and so I did not sleep and was alert all the time. Hence, I was so exhausted and worn out. After many nights of continuing no sleep, I finally dozed off and almost fell off from the chair. I left Tim Horton Day for hospital emergency room and any places that I could find to keep myself warm. A few other occasions, I would couch surf, staying with a friend and another friend. Never will I forget. As I struggled and tried very, very hard to find myself a place to live, one of my friend's church members rejected to rent the place to me because I stayed at Tim Hortons, thinking that I was mentally ill, not safe for her young children. In short, my whole being, physically, emotionally, and mentally, was so fatigued, stressed out, and anxious, which were unbearable at times. Eventually, when I was able to get housing, I had to move frequently due to bad, unhealthy living conditions. I always have goosebumps thinking of these unforgettable homeless days and constant moves. My living condition got worse after I lost my job. In fact, it got harder for me to find a decent place with affordable rent. One rooming house, I have to wear a winter coat to keep myself warm due to the lack of heat in the winter. And my legs got so swollen and cramped that I was unable to walk due to dampness and mold in the summer. Recently, my current landlord did nothing about flooding in my room due to water from broken backyard pipe. Since May, I have been sleeping without mattress on the wet floor with mold, which means I'm not sleeping well and often getting sick with diarrhea when my stomach catches a cold. And I have not been able to find a place with affordable rent to move out. Because of the dampness and mold, there were a lot of mosquitoes in the summer and winter as well. Most of the night, I'm tossing and scratching so hard to a point my body bleeds. With constant workout every 15 or 30 minutes, I only have 1 to 2 hours sleep at most every day. Prolonged lack of sleep has affected my daily life and caused danger to my body and health. I have poor concentration. I have often dozed off and cut myself while cooking and cutting. One time I dozed off and fell from the chair and broke my finger. As I have to cover much of my rent, transportation, food, and other basic need expenses from my basic need allowance, which leave me with very little money or no money to live on.
B, it's 3 minutes.
Pardon me?
3 minutes.
Oh, okay.
One sentence that cap.
Okay, I'll go to my last sentence.
Conclusion.
On September 13, Toronto celebrated 50 years birthday with a bash. My heart had no joy but sad. In fact, I felt pain and grief for the city, for Torontonians who are in poverty, struggling every day to meet their basic needs. I know you all love Toronto and care for the people under your leadership. Toronto look to you for change. We need you to fight for us against poverty and to clear any barriers that prevent us from meeting our basic needs so we can live in dignity. With your commitment and support, the city and Toronto will have a real big celebration when the final poverty deduction passed and the recommendation will be carried out to help the vulnerable with their basic needs.
Thank you very much, B. You did a great job. You've convinced us. I understand that, sorry, first thing I need to do is to move this motion and that the meeting be extended through the lunch break to complete the items on the agenda. Many people are leaving right after lunch, so all in favor, opposed if any, that's carried. Our last speaker, I understand Kabindra Sharma has come. Yes, come on in, come on forward. 3 minutes, please keep it tight.
Okay, can I start, right?
Yep.
My name is Kabindra Sharma. I'm the resident of Scarborough. I'm speaking with you to share some of my experiences with finding a job and sustaining a job for a longer time. and I recommend a solution for the city poverty reduction strategy because I believe sustaining a job is as an important issue that needs attention. Since 2012, I have been facing challenges for finding a job after being graduated from college. As an immigrant, it is difficult for us to gain an experience in Canada, and most of us organizations need the Canadian experience. I'll never forget one moment recently took place with me a couple of weeks ago. Without any hope for getting a job, I had enrolled into the certificate program 1 month before with Ryerson University. Before 7 days of starting the course, I was offered a job in staffing agency. I did struggle to do both. Finally, I dropped the certificate course with the hope of continuing my career. After a week of involvement in a job, I was terminated without any reason, though I was trying hard to benefit the firm. There is a little protection available for the people like us. Although I'm qualified enough to take up a professional job, but there is no job for us. As a new immigrant, we are facing this problem a lot. It also degrades our morale. If the parents are morally down, children will also suffer negatively and will hamper their psycho-emotional growth. So stress is present when an environment situation is perceived as presenting a demand that threatens to exceed our capabilities and resources for meeting it. It often occurs under conditions in which failure to meet the demand has important consequences. This creates a state of disharmony and imbalance between demand and response capability. You may all know that 90% of illness, disease is related to stress. Stress manifests itself as an illness, such as ulcer, heart ailments, and high blood pressure. During the first or second stages, the removal stage will eliminate the symptoms. So given personal experiences, this is my suggestion for poverty reduction strategy in line with the city's recommendation as highlighted in the interim poverty reduction strategy report on linking the health crisis to other provisions. So I'd like to request emphasizing on the forgotten half of change. We are all aware of technological changes. However, we are not aware of the forgotten half of change. Perception towards us, realizing how difficult residents are having to live even on a normal life. If we could combine both elements of change, then only change can take place. Otherwise, no matter how one is technologically advanced, when residents are struggling with the survival requirements. So we need you to fight for us against poverty with smart, thoughtful, and intelligent strategy. Thank you.
Thank you very much, Kabindra. We appreciate your comments, and you were right on 3 minutes. Perfect. You win the gold prize.
Thank you very much.
Thank you. Okay, so those are the deputants. Councillor Nunziata has to leave, and she held the item number 7 on the audit. And so with your indulgence,
I'll just release it, Mr. Chairman, 6.7A.
Okay, great. Thank you. This is around the audit. And just to if I could for 30 seconds summarize, there's a recognition that the health unit is audited in several different ways through the Ministry of Health and Long-Term Care. The city will audit, if this goes forward, the city's auditor will audit the pieces that are 100% funded, and those deal particularly with the mobile food truck, the student nutrition program, and the seniors dental program. So that's the division of labor. Okay, all in favor of that recommendation? Opposed, if any? That's carried. Okay, thank you very much, Councillor Nunziata, for the release. Now we move to back to the Toronto interim poverty reduction strategy. We have a guest councillor here who's been leading the efforts in this regard. Councillor McConnell, do you have any comments?
Yes, thank you very much, Mr. Chair. And first of all, I want to acknowledge the work that you have done in partnership with this strategy and you bringing it, first of all, to council, as well as your ongoing support as the chair of our health, public health. I also hope that, and I haven't spoken to other members of the committee yet, but before on this matter, but I also hope that you saw that what we did in the interim strategy was really a very readable and thoughtful piece of work. I think that the congratulations for that goes out to staff because they did a remarkable job of taking over 1,000 voices that we heard and distilling it into something that was fairly simple, something that could tell us what do we need to do today, what's the pathway to the more complicated things, and how do we make systemic changes so that we don't come back over and over and over again in other councils. We've looked at a direction that's up to 2035, but we also recognize that it's a living document and that we can't put something in place today that will deal with those issues in 20 or 25, or so that the notion is to get started on the road, to set out a framework, a roadmap, if you wish, and then to adapt it in a very thoughtful way as we move forward. All the members of the agency boards and commissions are looking at this. I'll just briefly explain that it was a very dynamic engagement process, and you could see that, I think, from the people who really, at the end of the day, whose voices we need to listen to. And those are the people with lived experiences who work and live in the community and daily have to deal with these matters, both in their own lives and in the lives of their neighbors. And so when we went out to the 10 areas that we had face-to-face consultations on, the issue of food security was a very interesting issue. In some areas, no one sat at that table because, and guess what, they didn't have any food security experiences. They didn't have community gardens. They didn't have any of those things. But when they began to talk about them, they talked about how far it was to get to the grocery store, how the transportation was very poor, how the nutrition of their children was very bad. And so in other areas, such as Northern Scarborough, in the Malvern area, they sat at those tables because they had had those programs removed. And so they knew how important they had been in the community. So I think that today you heard a synthesis of the sorts of things that I heard, and I hope that this Board of Health would endorse the general directions of the interim report, wait for the final report to come, and to send all of the notes of the deputants to our staff so that we can make sure that they incorporated it. But certainly today, we heard, as we did, the importance of food security. So we looked at 5 fingers: housing, transportation, services such as the services that you as a board direct, as well as child services and others, but also food security. We included that. And I think you heard today about perhaps one of the most important, which is employment, living wage, the costs of food for people on ODSP and for seniors. These are important issues that we as a city need to deal with, but also that will make a difference in terms of the new city that will emerge. Because right now we are in a moment in which our city is dividing so severely that it may be irreparable. And so it is important because you look at the health of our city, and the health of our city is reliant on the health of our individuals within our city, that I think that we hear really strongly about mental health issues, addiction, which you deal with, but interestingly about the care of the dental care that is so important. And now the emerging issue of pharmacare, and how many people are not taking their medicines because they cannot any longer afford them. I think that fundamental to all of this is the work around nutrition, the sharing of vegetables and gardens, the way in which that can break down many of the barriers and allow people to access to other services that might be available. And so from my perspective, I entirely agree with Leona, who brought forward the notion of getting all of our pieces together. That's really what we're talking about. We're talking about a lens that looks at all of the different challenges of our communities, a human rights and equity lens, but also a systemic change lens that holds all of these notions together and allows us to get our house in order so that we can work with other orders of government to make sure that where we dovetail, we can do it together, and where we're on parallel tracks, we can be supportive of each other. So those are my comments for today, Mr. Chair, except to say that I'm very happy that the LGBT community is going to have a further sounding, and I'm hoping that the Aboriginal community will as well. We have not had enough voices from those two areas, and we'll be exploring further work in those areas. Final report coming in November, and I'll look forward to any comments that you may have when that comes out as well. Thank you.
Great. Thank you very much, and thanks for all your great work. Peter, do you have comments or questions?
I have a comment.
Comments, okay, just hold on. Are there any questions of staff? Questions of staff? No.
I have a question.
Lisa.
Somewhere. It's in regard to the recommendations under further enhancement, just my understanding of that. Is that in the executive comment notes, there was a recommendation to report on the cost, the opportunity costs, that's not included in this material here?
No, that's not. The request that came to the Board of Health was to provide input to the city manager, including service implications. So we've identified some services that are within the ambit of public health that we think really are contributing to poverty reduction, some of which were funded in the most recent budget, which had an allocation for poverty, including the student nutrition program, for example.
But the further enhancements aren't in our package?
No, for the further enhancements refers to some of the things that we're asking for were already enhanced in last year's budget.
Okay, thanks.
Thank you. Other questions? Great. Okay, speakers. Dr. Peter.
Thank you, Chair. As a community pediatrician, a child health advocate, I also wanted to show strong support for this poverty reduction strategy, because we know that as many as 1 in 4 children in the city live in poverty. And we're just beginning to understand the relationships between poverty, food insecurity, and poor child health outcomes. So I think that addressing poverty really is going to be our next big public health challenge. I want to commend everyone who worked on the report and the strategy. And if I could, Mr. Chair, could I move to accept the recommendations of the staff report?
Yes, of course you can move that, yes. Okay, other speakers? Councillor Doucette, and then myself.
Just very quickly, I want to thank staff for putting this together and for Deputy Mayor McConnell for leading the charge on this. I've seen Deputy Mayor McConnell at 3 meetings, I think, this week. And what sorry, I'm not an all meeting. Yeah, you're running between meetings, and those last 2 weeks have been very busy because we've had back-to-back, well, side-to-side meetings. What I found interesting is in the committees I'm on, a lot of this overlaps. So I've already heard about the food access in other committees I'm on, and it shows how everything here dovetails into 1 committee, 2 committees. I wish we had all the money to implement this immediately. I know we don't, and I know it's a program and a project which will keep going. And I think it's been so important, though, to see what we can do, what we could have done in this budget for this year, which we have done, what we're looking to do next year, and let's make sure that that ball keeps rolling. Let's make sure that every year we are putting in the funds and revisiting, because maybe things will change. Maybe in 10 years' time, we won't be looking for new community gardens. Maybe we'll have all we need. Unlikely, but you never know. So I think, as I agree, this is this is an evolving document. It's not going to gather dust, no moss. It's not going to sit on a shelf. It's going to keep growing and growing. And I just want to say I support it 1,000%. And thank you to everyone who's worked on this.
Great, thank you. I'll just add some final comments by way of support. On City Council, we fight about a lot of things, all kinds of things. But one of the things about this report that first saw council in the summertime was frankly almost total, if not total unanimity, that we have a big issue in front of us, and that is the growing gap between those who have and those who don't have, and our need to really address poverty in our city. And so from the mayor's office to all four corners of the city, there is strong, strong support for the general direction in which we are going. There's also recognition, this is kind of a new area for us as a city. I think up to now, if we had a poverty reduction strategy, it was to point fingers at other orders of government. And of course, other orders of government need to work on EI, old age security, health, pharmacare, and so on. They have a big responsibility here as well. But I think what's new here is that we as Torontonians are saying poverty is complex, the solutions are complex, therefore, and we are a part of the solution. It's not just about pointing fingers, now it's about how we deliver parks and rec services, how we give out jobs, how we give out contracts, how we facilitate housing, and for our purposes here, how we deal with issues related, direct issues where we have a direct control in public health. So I do think it is a new moment. I hope we are successful, and frankly, you know, to those of you who are still here, we are going to be successful if a couple of things happen. One is if three things have to happen. Staff have to be strong and bold and noble in their recommendations that come in November, and there are great folks there, and I know they're going to do a good job. Council has to be politically motivated. This has to have a good politics behind it that spans all sides of council. That will make it a very strong strategy. And the third piece is basically community advocacy. We have gotten it this far because of your efforts. And those efforts have to continue so that between, you know, there's this, I've quoted before, there's this poem that says, between the desire and the act falls the shadow. We don't want that shadow to fall, and you have to help us make sure that that doesn't fall. This report is great because what it does, it gives overall support for the direction of the poverty strategy that is complicated, and it goes in 5 directions, as Councillor McConnell has said, but then it specifically addresses the 2 areas where we as public health will have a direct control, and that is in the area of dental care and the area of student nutrition. So I think it both does the general and the specific. And other committees are also doing the general and the specific. You know, if you're focused on child care issues, there's another committee that deals with that, and they will do a good job in their area. Our job here, and we need to be mindful, we're going into a budget meeting in a few minutes, we need to be mindful that we need to make sure that those elements are in our budget presented to the budget committee over the next few months.
Thank you very much.
Oh, thank you. Okay, so ready to vote? Okay, all in favor of the motion by Peter, opposed if any, that's carried. A motion to adjourn, we've finished our business. All in favor, opposed if any, that's carried. For those of you that are on the budget committee, you're welcome to stay, is it here? Yeah, to stay here. Now we talk money. We're moving into budget after a little bit of a pee break. Oh, okay, so we're gonna open the meeting first. All in favor of the, well, we're just gonna open the meeting. Maybe we'll just hold on a sec. Are there any declarations of interest pursuant to the Municipal Conflict of Interest Act? Seeing none, let's take a 3-minute recess. Okay, all in favor? Carried. Yeah.